in windy Edinburgh in Scotland. A warm thank you to the organisers of this Symposium of International Lifetime Medicine in Al Mamlaka Al Arabiya Al Saudiya, which I hope means the Kingdom of Saudi Arabia. And I do apologize if I got it wrong. Thank you for this kind invitation to speak with you today. Hello to everyone and wishing you all well. And I hope you're all coping all right in these rather unusual times. Before beginning my presentation, I just wanted to mention that the term lifestyle medicine was first used by the epidemiologist
Assalamu alaikum wa rahmatullah. Good morning, everyone. Welcome to the fourth day of حائل International Lifestyle Medicine Conference. Before starting our session, I would like to thank Dr. Farhan and حائل Health team for their concern on participation of private health sector in حائل to this conference. I'm Muhaib al-Adeli from Salamat Hospital. I'm a pharmacist. I'm thrilled to be with you. We will start our first session with Dr. Nasreen. Dr. Nasreen is consultant on family medicine at King Abdulaziz University Hospital. She will discuss a coaching training needs of a primary care provider. Welcome with me, Dr. Nasreen.
Thank you so much. Today, inshallah, I'm going to discuss with you a very interesting topic, and it's my passion actually, about coaching and why we need it in primary care. This one, I think, اسمه إيش؟ دوار القربة صح? We saw that it's very interesting. How many years, I don't know, but it seems like old, inshallah. So our outlines today, we're going to talk about coaching philosophy and why we need it in primary care. We're going to discuss as a case scenario and apply the coaching in the case scenario, health coach rules, and who can be a health coach. It's only physicians or everyone can be a coach. Behavior change stages. Just we're going to give you an overview about that. And health coaching outcomes, a local health coaching program in our Saudi Arabia. So let's start by coaching philosophy. Coaching philosophy, usually it's very simple to explain it with this type of talk here. Give a man fish and he eats for a day. So you can give a man ready fish and he can eat for a day, but teach man to fish and he eats for lifetime. And this is exactly what we are doing in coaching. We empower our patients. When we talk about health and wellness coaching, health coaching can be defined as helping patient to be active participant in the session. So when you are discussing with your patient his case, you give him options and he's the one who chooses. In their care so that they can reach their self-identified health goals. So the participant practitioner is only enabler. He's not the expert in the session. What different coaching other than counseling, for example? Counseling is the usual practice we are doing in our clinic. Counseling is advice and recommendation. So you are a physician sitting with your patient. You have only 15 minutes. You have to give him a ready plan. So you have to increase your insulin, for example. You have to do 15 minutes exercise. You can do whatever. So you are just recommend and advise your patient during the session as counseling. And this is make coaching a little bit different. Coaching inner game. This is very simple equation. It's performance equal potential minus interference. For every session, if we decreasing interference in patient options and patient decisions, this is make the patient really strong enough and empowered enough to design his own goals and his own plans. We have a lot of models to be used in coaching, but this one may be the most simple one. It's called GROW model. GROW model, we are map during the session. So G for goal, and as R for current reality, O for options, and will for the way forward its plan. Goal have to be smart. So when we are designing in the coaching map during the session as a GROW model, we have to have a goal like SMART goal. So we have specific time, when have to be done doing his goals and his plans. So when and how and what, it's very important questions we ask about it in the goal. For current reality, it's very important because sometimes we are talking to the patient and he's already doing a lot of trials. So just ask him what you did and what we can do now. If there's any previous experience was done, it was successful, we can use that in our session. Options extremely important. And this is make the patient feel that he have this ability to choose. I am not the one who's telling him you have to do this or this. He have all options and he's the one who can choose what he want to do. Will and way forward is for planning. So you have to give the patient or design a plan with your patient before he's going out from your clinic and coaching session. Okay. The most important question here, why we need a health coach in our primary care? In last 3 days, we was discussing all struggles and barriers for the family physicians in primary care regarding time. We have no enough time to do coaching and make patient options and explain everything. It's only 10 to 15 minutes you have to finish. I know it's different sectors. For example, in MOH, most of physicians, they said you have 50 patients, have to finish in 4 hours, for example, in military hospital. And so it's different. Most of physicians all over the world have this problem. So I have not enough time. So a coach can overcome this problem. So you are a physician, designing with the patient, discussing with the patient, and the coach will gonna continue the journey for you. Also, half of patients leave primary care not understanding what we are already taught to them. We are giving a lot of information, a lot of discussion, discussing his labs, his lifestyle, what he's doing, and his leave, he don't know what I have to do. I have to start from where. So this is very important that we can use the coach to make the patient understand more, or just to assure that the patient really understand what we are already agree for to do. This is really something disappointed. It's only 9% of patients participate in decision, and this is reality. Average adhere rate for medications, it's 50% of patients, they can adhere to medication, and 50% they are not. But when you come to lifestyle changes, it's below 10%. Because in lifestyle, we are acting on change behavior. Change behavior, it's consequence and it's a journey. So if I just tell the patient, you have to walk, you have to eat healthy, you have to sleep well, and we are not talking really about goals and plans, the patient, he cannot adhere what you are already saying. In the face of these discouraging statistics, primary care must take to a new task, because this is long time problem. Working with patients to ensure that understand and agree with participants in management of their chronic condition, this is very important. And health coaching is one way to accomplish this. In acute care, we have emergency, surgery, quick plans, so it's acceptable to be very fast. But in primary care, we are dealing with chronic disease. We are dealing with life change. We are dealing with a lot of things. So we need to empower our patient with knowledge, skills, and confidence to participate in their own care. And this is really something difficult. We need to have very specific sessions for that. So in primary care, most of our problems sitting here, and diet, exercise, sleep problems, alcohol, smoking, behavior and lifestyle, and these of our problems going with infections and genetics and all these issues. So we need to really move toward different approach with our patient. Let's discuss case scenario. This one, he called Mr. Osama. He is diabetic, hypertensive, and dyslipidemic. He's on multiple medications. Following Dr. Fadwa since last years, she see the patient for 5 times in last year. He's already on 6 prescriptions. When he gave up eating candy, he thought that would solve some of his problem, so he stopped taking several medications. Mr. Osama think with himself that I'm uncontrolled diabetes, so let's do something new. And he stopped to eat candy. And at the same time, he stopped some medications of his diabetes. And he's using glucometer at home, and he's measuring his blood sugar at home. And he just recorded and bring it to his doctor as usual. When Dr. Fadwa saw these high readings, she became frustrated. So finally, Dr. Fadwa decided to introduce health coach to Mr. Osama. Okay, she is Ms. Saad. Ms. Saad sit with Mr. Osama in a sitting of coaching, and she let him write down his most important health goals. And then she helped him link his desire to avoid amputation experience by his brother to importance of taking medications and changing his lifestyle. And this is very important to, when you sit with your patient, as we discussed before, that you take the motivational message, why you want to change your life, why you want to, for example, do exercise, eat well, take your medications. And she teach him the skills of interpretation of glucometer readings in relation to food and exercise and medication. So the patient become empowered, and when he see the blood sugar readings, he can react. So if high blood sugar, what he have to do? If low blood sugar, what he have to do? Within 3 months, Mr. Osama A1C dropped to 7. So it's rescuing means telling him what to do about his current glucometer readings, a passive patient. So each time he's just recording blood sugar readings and come to his doctor and tell him what you think. And she's the one telling him this is good and this is not good. But if you empower your patient enough to react very well to his blood sugar readings, how to do exercise, how to diet, how to set his health goals for long term, he will gonna be empowered, and maybe he will just come to you every 6 months, a year. So health coach rules. It's a lot of rules actually, but the most important that to empower the patient enough to set his own health goals, long-term goals and short-term goals, as we explained before. Also providing self-management support. So you train your patient to be active participant, not passive participant. Helping patient navigate the healthcare system, and as all of you know now, every health sector moving to electronic device. So our patients, for example, if he is old, 60 or 70, have a problems, he needs someone to help him to navigate his system. Offering emotional support, this is extremely important in the patient, especially when he's doing new behavior and changing his lifestyle. He needs someone to support him in his journey. Serving as continuity figure, and he's the one who can contact the patient weekly basis. As a physician, it's very difficult to do that, but he can do that. Bridging the gap between clinician and patient. So who can be a health coach? It's only physician, or what do you think? Exactly. Thank you, Dr. Saleh. So any health provider can be a health coach, anyone. So physicians, health educators, nutritionists, nurse, anyone trained to be a health coach. As a health provider, he can be a health coach. Just to give you a clue about behavior change, because this is part of coaching. It's very important to empower your patient enough to do behavior change. Behavior is the way which one acts or conduct oneself, especially toward others. So all of us know these stages of health, of behavior change, starting with pre-contemplation, contemplation, preparation, action, and maintenance. So usually the most difficult stage is pre-contemplation, contemplation, and maintenance. Because if you are taking already preparation and action, already you have this motivation enough to do. But to maintain this new health behavior, it's difficult. This is stages of readiness to change, and it's going according to pros and cons. This is very important to discuss it with your patient in behavioral change session and coaching session. So what's your pros and what's your cons? In the beginning, the patient will have a lot of excuses, and as Dr. Salih Al-Ansari always saying that, I have a box of excuses. So I'm doing that in the clinic. I'm just giving an empty box, and when the patient tell me any excuse, I just put it on this box. This is cons. Pros, if you do this, what you will gonna gain? So the patient will gonna, okay, I'll be more healthier. I can walk, for example, for long distance without tachypnea. It's a lot of pros. With time, this study showed, with time, the patient, with the behavior change, and when the patient seeing this very good outcomes, the cons are gonna be decreased. So no more excuses. The patient will gonna really know the excuses. It's something only not real. Okay, now here we have, in 2017, 150 studies, 72 randomized controlled trials, and two systematic review. It showed that the interference of coaching on these diseases as outcomes. Obesity, we have 13 RCT and another 31 studies, showed 87% significant weight reduction when we are applying health coaching with the patient. Diabetes, 14 RCT, showed that 78% significant reduce in A1C. And wellness studies, 15 RCT showed 92% enhanced exercise behavior and 88% enhanced nutrition behavior. Hypertension, 7 RCT showed that health coaching can lead to 67% significant lower blood pressure. Heart disease, 7 RCT showed 91% significant lowering disease risk. And in cancers also, 67% showed favorable outcome, especially in psychological quality of life. So these readings here, it's really promising regarding the health coaching outcomes with these very common health problems. But again, health coaching have a barrier because health coaching is supposed to be done as supposed to be. It's strategic and it have to be in a specific manner with according to, for example, the health coaching program which is doing in Saudi Arabia or in ICF, or you have to have very clear strategy you are going with in coaching session. So this is according to ICF. This is a local health coach program was done. It's called McKin under Ministry of Health. This year it will gonna be the second graduation. Supposed to be. They said they graduate in this in 2021, 30 trainees, and they are doing this health coaching program for 10 weeks. It's with the work. So it's okay to be working at the same time, just attending these lectures and doing this practice beside your work. So this is, for me, it's a promising local program, and we sectors having this type of program because, as we discuss here, in primary care, we need them in our system, even empowering our physicians to have this skill and competency as a health coaching or any health worker in the team. So achieve effective health coaching, we need full health team engagement. So again, always remember to teach your patient to fish instead of give him a ready fish. These are my references. And you have any questions?
Thank you, Dr. Nasreen, for informative and interesting presentation. Do you have any question? Okay, the question will be at the end of the session. Okay. Now our speaker, Dr. Mohammed Zayed, will discuss the antimicrobial stewardship implementation in Case A experience. Dr. Zayed is graduated from King Saud University, and he got the residency program in clinical pharmacy. He is from حائل Health Directorate. Welcome with me, Dr. Mohammed Zayed.
Thank you very much. Assalamu alaikum. صباح الخير جميعا. I would like to thank Dr. Saleh and Dr. Farhan to give me a chance to participate in this amazing and optimizing conference. And I will talk in general about the introduction or elaboration to the role of the pharmacist and the lifestyle medicine in general. But I will be focused on stewardship antimicrobial because I like this field. I think this is very important in our conference. I will talk about some concept about the medications, some schools or some concept about the anti-medication viewed as antithesis of lifestyle medicine. Well, actually, Dr. Nasreen, she talked about we need engagement of the team, and should be all the team will be included in the any clinical practice. And also related of the perception of the pharmacist only as a dispenser of the medication, we have to change our background. However, if we have the pharmacist have full trained, suppose have high knowledgeable background, and also it's suitable for about the screening, prevention, treatment of the chronic illness, and also suitable about the medication counseling. Pharmacists are well positioned to promote lifestyle medicine through health and wellness coaching, and are effective in doing so. I will talk about starting with the community pharmacy because this is a most accessible form of the healthcare, because the people limited to access primary care or the hospital. It's okay, I can go to the community pharmacy, I can get the medication, I can get the counseling, I can get everything from the community pharmacy. And also OTC medication, it's suitable to be taken from the community pharmacy. And about the refill prescription, even if the patient he went to the clinic and takes the medication, suppose there is a plan continue for 3 months, 6 months, need to be refilled prescription. I think mandatory to be give him a proper counseling, a proper to improve the quality of the therapeutic plan, and also the medication counseling. In the United States, roughly 13 billion pharmacy visit each year in the United States. This one, around 4,000 pharmacy visit each week. And this type of the convenience is a highly touch with the patient when you deal with the patient. This is lead us to be necessary demand of multidisciplinary team in clinical practice. I think Dr. Nasreen talked a lot about the integration, and also the team should be collaboration to be improve the quality of life, because we have only one target to be improve the quality of the life of the patient. I will go quickly about some studies discuss this issue about this is published in 2018 about long-term outcome of the cardiovascular and diabetes risk to reduction, the risky. This is nice studies, longitudinal 5 years, quasi-experimental pre and post-enrollment studies, focus on the hypertension, hyperlipidemia, and also cardiovascular disease. The conclusion for this one is the significant changes improve the quality. Also, there is some cost effectiveness found it after 5 years. Also, another studies that when we discuss about the clinical and economic benefit of pharmacists, involvement in the community, hospital, affiliated patient-centered medical home. This is also measure the intervention of the pharmacist in the therapeutic treatment, whatever about the OTC medication or any medication related to the chronic disease. With the arrangement with the other healthcare providers, we get the benefit about to improve the life, and there is benefit or reducing the drug cost. In our KSA, we have nice project. This one, National Antimicrobial Stewardship Program in Saudi Arabia. That one started this project in 2013 by by the General Administration of Pharmaceutical Care. This is published by Dr. Yusuf Al-Aoumi at that time. This is a nice project, mandatory. This is very important with the collaboration with the team from the pharmacy and the nurse, and also about the physician. Why this is program? It's a focus about found there is misabuse of the antimicrobial. This is very important to be focused on this issue, because if we misabuse this antibiotic, it can be harmful to the patient. And also there is a costly issues related to the abuse of the antimicrobial. We found it around 77.6% from 327 community pharmacies dispensed antibiotic without prescription. And also there is another cross-sectional study showed up to 51% from 200 plus medication dispensed without prescription. This is, I think, a big number. And also some patients have poor perception. This is very important to be improved the awareness about the using of the medication, especially for the patient. I think this conference, my colleague, it's making amazing job for the improve the public awareness related to the lifestyle. There is a study showed that the more than 50% of the patient not aware of dangers of antibiotic utilization, and 50% recommended antibiotic to their family. This is drug, it's a good, suitable for me, it can be given. It's okay, I have tonsillitis, I have any, you can use it. This is a good one. And also the high resistance increase the economic burden on healthcare system by 20 to 60%. This is project included in Saudi Arabia and also the Gulf countries, reduction healthcare associated infection and decrease the length of the hospitalization period. Also reduction of the mortality and reduce antibiotic cost. This project started from the scratch in 2013 and put it some strategies and some plan and put it some initiatives. And my colleagues are making amazing job in the Ministry of Health and Pharmaceutical Care Administration for this project. Started also 2014 and also put it some stages, put it some committees, put it also some policy and procedure. Discuss for the regional about a lot of issues related to the Antimicrobial Stewardship Committee. And also put it some indicator. This is very important to be measured after implemented the this project. which the cities in Saudi Arabia put it to the committee, central committee, and also regional committee, and also put it some privilege for antimicrobial. Also, in the same time, وهذا يعني وزارة الصحة ممثلة في إدارة الالتزام General Compliance Administration عملت حقيقة يعني عمل صراحة جدا خصوصا في الكوميونتي فارماسي إن عملت restriction of the using of the antibiotic unless if you have prescription. وحددت يعني بعض الأمور المهمة اللي عملت regulation حقيقة إنها تمنع صراحة abuse for the using of the antibiotic or antimicrobial in general. الامر هذا طبعا قد يسوقنا، يمكن الدكتور صالح موجود الان، يسوقنا الى انه حقيقه يحصل فيه ريدكشن للنورمال فلورا، والمشاكل هذه تعمل لي كومبليكيشن كثيره، بالاضافه انه قد يكلف تكلفه اكثر يعني في للفرد في علاجه او في احتياجه الى مضادات حيويه اخرى. I will mention also in Saudi Arabia there is nice studies by collaborative team. This is by Dr. Awad Al-Umari and also my colleague in clinical pharmacy, Saad Al-Hamed, put it nice studies, that one in Al-Habib Hospital. This one, impact antimicrobial stewardship. This group put it antimicrobial stewardship program and measure the benefit and the cost effectiveness for some antibiotics like imipenem, piperacillin, colistin, tigacycline, and cefepime, and ciprofloxacin, moxo, and also linezolid, and measure the benefit after the implement the antimicrobial stewardship and put it some restriction. At the end, we get the benefit for reduce the incidence of healthcare associated infection and also reduce antimicrobial cost. As you see here, it started from 2015, and if you see the expenditure and also saw some expenses and really actual saving, the cost if you go for 2018. This is, I think, a good idea from the private sector to be started antimicrobial stewardship. And also in Hail with my colleague, Dr. Mishal Al-Ataibi and Dr. Yasser Al-Habib and also Dr. Nader, Dr. Ihab in King Khalid Hospital, we make it effect of carbapenem restriction on prevalence of carbapenem resistance Acinetobacter. That one in King Khalid Hospital. This study divided in two periods, that one retrospective and prospective, and measure the benefit after the put it some restriction and privilege when using the carbapenems to be avoid the resistance. After that, after the implementation restriction can be gonna affect the strategy to decrease the prevalence of the resistance, and also there is some cost-effective issues. This study published in January in this year in the infectious disease in clinical practice. Take-home message: I think we need education, and we need also to improve the awareness also to the public about the health and using of medication or the nutrition or whatever. Also, multidisciplinary team is a very important. I think we need to be working together as a pharmacist, as a physician, as a clinical nutrition, as a nurse. All the healthcare providers should be integrated because we have one target to improve the quality of life of the patient. And also evidence-based, I think we need to be more research, more studies, more publication to improve our practice and improve also the quality of the life of the patient here. This is my friend, my son, Turkey. Thank you very much and welcome for any question.
Thank you, Dr. Muhammad. Now we will start to receive any question or comment about the two topics with Dr. Nasreen and Dr. Muhammad. And for online audience, just raise your hand if you have any question or comment.
First of all, shukran, Dr. Nasreen, shukran, Dr. Muhammad. Nice, brief presentations. I just have a few comments because I got questions before on the schedule too, so I'm going to answer the two. First, Dr. Nasreen, you talked about compliance with lifestyle medicine changes or lifestyle changes or management. I think the issue is not that it's a problem with lifestyle versus medication. We know that medication compliance between 40 and 50%. I think the issue is how we practice, because when the patient comes in, it depends on the interaction between the provider and the patient themselves. Also, we're missing a lot of links, starting with nurses, pharmacists, and others. We're not enforcing each other's message or plan because the pharmacist doesn't know what we're doing, and we don't know what the pharmacist is doing. I remember when I was in the States, the pharmacist will call me if there is any issues, and also they would review the medication of the patient, making sure there is no interaction, there is no food or other problems that could interfere with the medication or medical management. I think what we're missing here in Saudi Arabia is this one part, and I second Dr. Muhammad's call for collaborative, more formal training between physicians, pharmacists, nurses, nutritionists. So we're given the same, or at least we're coordinating care properly between the different levels of healthcare. And this is what lifestyle medicine brings in. So I think sustainability and regular enforcement, what we do in the clinic, in my clinic at least, the patients will be asked their medications, their lifestyle changes, how are they responding, if there is difficulties, side effects. Lifestyle changes do have side effects. Most of them are good, and sometimes they're not, especially depression. So your comments on that, and then I'll finish with pharmacy, inshallah.
Okay, thank you, Dr. Saleh. This is really important. And usually, as we are saying, as a physician, you cannot work alone. You need a team. So supposed to be, if we are talking about mindset of lifestyle medicine, we have to enforce and empower all our team members. Whatever someone covering in the clinic or outside the clinic, they have to know our message. They can take a lot of load other than from, for example, if you have only 15 minutes, maybe 5 minutes of that 15 minutes go only to explain how to take medication and when you take medication, if this happened, what you do. But if our great pharmacists sharing in this, they can take this out. As a coaching, it's a process of changing mindset of the patient. And to change mindset of the patient and behavior of the patient, you need to sit with the patient really, really in strategic session. And we can do it as physician in multiple sessions, but we have to deal with our team members, I agree. If you have an educator, if you have a nutritionist, if you have someone, and make sure in every visit of the patient, what happened, and if any barriers, how you deal with it. This can really help a lot.
Dr. Nasreen, I will emphasize, and probably we need to do research on the complementary and collaborative roles of different levels of healthcare delivery. And maybe our next conference would be a team-based lifestyle medicine approach, solving some of the problems in the healthcare system as we see it today. Dr. Muhammad, thank you for your. It's difficult for some of our colleagues to see the relationship between pharmacy practice and medical practice, even nursing and nutrition. But I think we need to push forward and getting everybody to be on board, because just prescribing a medication and then dispensing the medication, that's not the end of the game. I think pharmacy also need to improve its practice, i.e., they will look at the medical record. What is the plan? So maybe call the physician and said, okay, your plan is to do a lifestyle medicine intervention, and you decided 1, 2, 3 with the patient is an active participant. My recommendation is not to use this medication sometimes. I mean, sometimes maybe patients do not need to take Ozempic or take Ripulsas or take whatever medication. And we see in the clinic patients improve with just lifestyle intervention for even diabetes type 2, that's a new onset diabetes type 2, hyperlipidemia, etc. And you will be amazed at the results. Now, this is one of the goals of 2030 vision, which is decrease the economic burden. So I think doing that, but we need to expand the training of lifestyle medicine to go beyond just physicians. We need to go to nutritionists, even level bachelor degree. And also enforcing compliance. I think if we all focus on compliance, not just medication, even lifestyle changes, and it becomes a practice on every visit when we see patients, that would help us a lot. And my patients, what I do, bring your medication with you every time. And I put it on the table, review it, and we'll see what we can reduce. And patients are happy that you're doing that. And also you'll discover a lot of redundant medications with different brands, different companies. And this is when you get complications without knowing the source. So I'm calling here to take full advantage of pharmacy practice and get our colleagues in pharmacy to be trained also in lifestyle medicine from their point of view, from their side. And hopefully over the next year, we'll have done a team-based approach. I know pharmacy is not included, but we will include it in lifestyle medicine. Any comments from your side?
Thank you very much, Doctor. Inshallah, we hope, as a member of this issue, and also I think all we are integrated together to improve our practice. Thank you.
Thank you, Dr. Nasreen. Thank you, Dr. Muhammad. Actually, Dr. Muhammad, it is an important topic and excellent presentation. I think it's difficult probably to solve the problem with antibiotics, and the people believe in antibiotics despite they even didn't fulfill or finish their course. What about the microbiome? Do you think we can solve the problem with antibacteria or antibacterium medications with microbiome? And is there any microbiome now available in pharmacies that we can help these sort of people?
Yeah, it's okay, Doctor. Thank you very much. I know we focus about the abuse of that one antibiotic. It can be affected. It can be using the microbiome, but really we focus about when the patient is in need the proper antibiotic and proper indication, clear indication, sometimes needed to, even if prescribing, needed to be proper instruction for him, needed also to be continue with the patient and with the healthcare provider about the doses, side effect, everything. I know we have another solution or alternative, but also at the same time, in case of the patient, he needs the antibiotic, need to be also monitoring. And for example, in our practice as a vancomycin, it's okay, it's indicated for the patient and you can give it, but should be monitoring the side effect and also monitoring the drug level in the blood. And also sometimes need to be adjustment to dose.
Assalamu alaikum. Dr. Nasreen, Dr. Muhammad. I have each question for you. Regarding Dr. Nasreen, regarding the patient, there is a patient in the clinic and there is a caregiver, like a son or daughter. The patient, let's say he's in 50s, 40s, like sometimes we don't call caregiver. Me as a physician who, let's say, for example, study life coach or know the ways or what to do for the best medication or approach for the patient, should I give a life coach both of them or just only the patient, since it's patient anatomy and has the right to stop medication or leave the clinic? You know what I mean? and Dr. Mohammed.
بس عشان if I understand you well, you mean that if you have a mother with her daughter, for example,
Yes.
and the mother is she want to stop the medication and she do want to follow your advice, or what? I didn't get.
Sometimes there are physicians that when they give advice, they tell advice to the daughter, not the mother, which is the patient. Like, tell your mother to take the medication and to go and let her to go to walk a lot or do exercise a lot. Not telling the patient. ما تقول للpatient وهي تقول للبنت ليش يعني.
يعني just she is talking to the daughter and avoiding talk to the mother. This is what you mean.
Yes.
Yes. Okay.
And regarding Dr. Mohammed, it's very, you're right, it's very important to give awareness regarding the using of antibiotic to prevent resistance. But there are patients, unfortunately, for example, they have got pneumonia and I prescribed him antibiotic. He or she didn't complete the course, and for example, 2 days, and didn't complete the course. Went to another clinic and say the same symptoms of pneumonia, for example, and took another antibiotic. Is there like a solution for this? Or like a system that they say, oh, you already took antibiotic, you should complete your course. Is there any kind of solution for this? Thank you.
Your question about the compliance of the patient and the antibiotic. It's okay. And I know this is a big challenge with us about the compliance of the antibiotic, but I think she need, I put it also, need education, need complete awareness of the public, and also need to be discussed with the patient exactly and clear, put it the plan, and we should be shared the patient to put it the plan, because he's a very important stakeholder in our institution. In case of the is not compliance, must be also to be put it, what is the difficulties, what is the problem, what is this one. I know this is a big challenge, but we hope to be improve the quality.
اسمح لي.
طيب بالنسبة لسؤالك الأول دكتورة, this has happened, yes. When you have a patient and a relative, this is usual scenario, especially when the mother or father or someone, usually there is a relative with her, or husband and a wife. This is one of the sessions that we train to deal with as a physicians, because you have to take care of the patient. In the same time, you have to involve the other person, especially if this person is a caregiver for the patient. But if this type of practice, if the physician avoiding talking to the patient and only concentrate on caregiver, this can happen, but this is, as all of us know, it's not right, because the patient, she's the one who can follow the advice, discuss and explain to you that I cannot walk, for example. I cannot eat this type of food. I cannot sleep at night, especially old ladies. So if we are not giving this time to the patient and make her express herself, we're gonna lose her. And totally agree with you. And maybe this type of session is really difficult and you need more time. One of solutions, you can ask the nurse just to give you more time and take your time with the patient and involve the caregiver. You can give her frequent advices, recent, so you can give the advice on multiple visits. Give her this time to express herself, empathize with her, because this is really important, the old ladies need, and all patients of our patient. And coaching is really helpful with this type of sessions. Thank you.
السلام عليكم ورحمة الله. أحمد فطاني في الوحدة الطبية. كومنت أولاً وشكر للمؤتمر والفرصة الطيبة لجماعتنا معكم ومشاركتكم الرائعة لكل ما قدمته من علوم ومن فوائد. إن كان تسمحون نشارككم بتجربة صيدلانية فيما يخص اللايف ستايل، وسؤالين إن كان تسمحون لكل من المشاركين. عادة ما يرجع المريض للصيدلاني يقول له الدواء حقك ذا ما يشتغل أو إنه آذاني. فأكثر المرضى اللي إنه الدواء ما صار يشتغل زي الأول. وطبعاً جزاه الله خير من عرفنا على طب نمط الحياة وأدخلوا الدكتور صالح والمجموعة. بدأنا معاهم نصايح باللايف ستايل، فصاروا يرجعوا يشتكوا من إنه الدواء صار أوفر بالنسبة لهم. وبدأنا فعلا نشارك التجارب هذه مع مرضى آخرين، وفي خطوات إن شاء الله إنه يكون في عيادة صيدلانية متخصصة في التابرينج داون للميديكيشن، ونحن نتكلم خصوصا على دايابيتيك بيشنت. حتى إنه في قصص كثيرة ممكن نشارككم فيها إن شاء الله في مؤتمرات جاية. أنت فتحتوا الباب الصيادلة، كلكم من الشاكرين فيما يخص اللايف ستايل امباكت على عافية المرضى، وبعضهم الحمد لله ربي ييسر له ما صار في حاجة إلى الدواء. سؤالي إن كان تسمحي دكتورة نسرين بالنسبة لللايف ستايل كوتش، البرامج اللي شفناها في غير السعودية ممكن توصل إلى سنة، وبتركز على أشياء إضافية فيما يخص الجولز والسيت اب للبيرسون نفسه. فإن كان 6 أسابيع التدريب موجه الجزء من هذا، أتمنى تبين لنا كيف، عشان لأنه هذا له أثر كبير في استعادة المريض لنمط حياته الصحيح، خاصة فيما يخص النوم والعادات الأخرى، بالإضافة إلى التغذية والعلاج. ودكتور محمد، سؤالي لك الله يسعدك، هل بروتوكولات الأدوية ممكن أنها يضاف إليها البروبيوتكس بعد ما ينتهي الكورس؟ لأنه في بعض الممارسات في مستشفيات زميلة صار بعد ما الطفل ينتهي من الكورس حقه يدوه البروبيوتك باي بريسكريبشن من الفيزيشن، وهذا صار فورمولري ميديكيشن موجود في كثير من المستشفيات اللي تعتني بالأطفال بعد الكورس. شكرا.
طيب شكرا جزيلا. حضرتك من وين؟ من الرياض ما شاء الله. وبتقولوا بديتوا براكتسينج اللايف ستايل في
عن طريق تعاون مع الزملاء في جامعة الملك في مستشفى الملك سعود.
مرة ممتاز ما شاء الله. We're gonna glad to hear from you inshallah the outcomes, because you said that many patients stop their medications, so this is really interesting.
Not less than 20 we have, even بعضهم maximized insulin in 4 months. ما شاء الله تبارك الله.
ما شاء الله.
And this is where they keep going back to the physician and asking for appointment, and they did not find that an easy job. So they come back to the pharmacist and ask for an advice, and still we send him to that appointment. However, he benefit from the advices from lifestyle, and we wish that we can have more access to the tapering clinics where we can manage those patients, but still it's not how can I say, policy or organized. Yes.
And your question regarding the coaching for 6
weeks.
Yes.
Does that going to be enough to cover the patient's sorry, the coach abilities to guide the patient in his first plate? What come the most, like his personal goals, what can remove the stress, what can give him back the normal life?
Yeah. This is excellent question actually. And usually the patient when come in lifestyle sessions or coaching sessions, they ask how many sessions I need to implement the behavior or to change my blood sugar, for example, or to decrease my weight or whatever. And there is no answer for that, because it's depend on your patient, depend on the progression, improvement. Any changes happen in between. For example, the patient have stress, have no good response. So it's depend. But usually as international statistics, 6 to 10 sessions at least. But maybe more, maybe less. It's depend on the patient response, depend on the patient progression. If really is setting the goals was set before, it's achieved or not achieved. Thank you.
Dr. Mohammed.
So your question about the update antimicrobial, that one program?
If we can add to that stewardship that we the pharmacists recommend the probiotic after completing that course. So this will give you two double check to the endpoint that the patient is free, and the next thing is return him back to the normal life.
Yeah, very important this one, and we can also I think this our colleague in General Pharmacy Administration will be inshallah added and accept any recommendation, any suggestion to be improve and add everything.
Okay, thank you. We have one question from online.
السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله.
معكم دكتورة مشيرة عناني. I'd like to thank the organizers, Dr. Farhan, Dr. Saleh, for an amazing conference. I'm participating tomorrow virtually. I have a question and a suggestion for the stewardship and lifestyle. Initially, I did not find really a direct link. I thought this lecture was a bit deviating from the theme of lifestyle medicine, but not only educating the patient on the resistance and, of course, the harm, the adverse events of unnecessary antibiotics, as well as the provider. But we need also to focus on maybe the microbiome. When we use antibiotics, what will happen to microbiome dysbiosis and the consequences of dysbiosis that was discussed by Dr. Dania, including, of course, a lot autoimmunity, allergy, as well as even obesity and leaky gut. So if the patient is a bit scared about, because sometimes the pressure comes from the patient, they request antibiotics, and the provider is just, trying to please the patient and prescribe it. So if the patient, pharmacists and providers are educated on the harm induced on microbiomes by antibiotics, unnecessary. Most of the time it's unnecessary. And in my practice, every consult I go, I have to stop or de-escalate antibiotics. It's really disturbing how much unnecessary antibiotics are being prescribed. So maybe that's instead of giving probiotics to the patient, okay, if it is necessary and appropriate, then maybe we have to educate the patient also on healthy food, probiotic, natural probiotics that can be obtained from food, also fiber-rich, food and prebiotic, rather than giving a probiotic, because not all over-the-counter probiotics are studied in a randomized controlled trial. I'm sure we have to be evidence-based, and we don't have to just prescribe anything available in community pharmacies. We have to make sure that this has been studied, it has been safe and effective. So until we find the evidence, which is very few, I haven't come across a randomized control trial. So maybe nutrition. We have to, there's two opportunities: educating on nutrition and nutrient dense as well as fiber dense food as a prebiotic, as well as what happens to the microbiome with antibiotics, especially when it is unnecessary, when it's a prolonged course. So I thought just to have this comment. Thank you very much.
Thank you, Dr. Mashira. Now we will start the second session of the day with Dr. Marwa Abdessamad.
Good morning. I hope you all enjoy our cold weather in Ha'il today. Our session now we will start it by virtual online session with Dr. Celi Tanegua from Brazilian. Dr. Celi is certified as the lifestyle medicine physician in 2017. She led the Brazilian College of Lifestyle Medicine. She was the president from 2020 to 2021. She will talk about very important topic, and I think it will be very interesting for all of us about the behavior changes and how to influence our patient. It is very important topic. I think we need all to hear from Dr. Celi about this very important topic. Hello, doctor.
Hello.
Are you
Hello.
Let's welcome Dr. Celi.
Thank you very much. I will share my screen. Okay, so hello. Well, maybe you are surprised, a Brazilian speaker with a Japanese face. It's because my great-grandparents, all of them were from Japan, and they migrated to Brazil. So that's why we are here. And here in Brazil, it's 3 a.m. So my husband and my kids are sleeping. but I am very, very happy to be here to talk to you at the Hale International Lifestyle Medicine Conference. It's a big honor, especially to be so far, but so close in humanity, right? We will discuss the art of influencing patients' behavioral changes. This is a theme that I love, that I study a lot, and I believe it's key to lifestyle medicine processes. I was listening a little bit of your discussion about the importance of the coach in health and wellness processes. And yes, it is all about it, okay? We use a lot of these tools of health and wellness coaches to help our patients change, okay? Because what happens is that when we start studying lifestyle medicine, we are touched by the scientific evidence of these 6 pillars, okay? It's amazing how simple lifestyle changes can, at the end, bring so many years to our life, but especially life to our years. And this is what we are all talking about, okay? We are talking about living longer with less diseases, but most importantly, days which are very well lived with emotions, with our presence in our totality. And this is something that is amazing, the results that we can achieve through lifestyle medicine. But on the other hand, as professionals, but also as human beings, we know how difficult it is. You know, we see how long it is the way between what we deeply want to do to what we can actually do. This is something that I believe is something that all human beings need to face. And it doesn't depend on the culture, it doesn't depend on the nation or on the belief. I think this is something that is true to every human being. Okay, so when we start learning about lifestyle medicine, for example, after this conference, I believe many of you will be touched by the lifestyle medicine message and will think, okay, I need to start I need to start eating more vegetables. I want to exercise more. I want so many things. And maybe at the beginning, you can do all these things. But after a few weeks, you become a little bit lost and you feel that you are not able, you feel like a failure, you have many other feelings. And this is true. This is something that happens to you, and this is something that it will happen to your patient. So I even believe that this is something good, because when we feel these difficulties, our empathy levels with the patient increase. And when we have this empathy increasing, it's the way where we connect and where things start to happen, okay? Because, well, to practice lifestyle medicine is so much more than just this. Oh, yes, you should eat more vegetables. You have to exercise more. You should sleep 8 hours every night, or you must lower your stress levels. So start meditating. When the patient listens to all these things, wow, his mind goes, oh my God, I am lost. What am I going to do? I think it was easier to take some pills or maybe consider surgery because it's so harder. And yes, it is so harder. That's why we need to use many, many scientific evidences of communication. Okay, that's where we can use all these tools from lifestyle, from health coach to help this patient through this long way. Okay. What do I usually do? Okay, I am a physician, so I have my usual appointments with the patient, but I also include this lifestyle medicine evaluation. So with his physical exam, his medical history, with the lifestyle medicine evaluation, maybe with some images or lab exams if they are necessary. I take all this information and it's my obligation. I give this patient this professional orientation. Okay, these are my recommendations to you. However, the biggest change when I discovered lifestyle medicine and with the results with my patients was this part here. After having these orientations given to the patient, we co-create an action plan with the patient. And this moment, it's not just my signature, okay? I put my signature and my patient's signature on the record because from now on, we are creating everything together. So our responsibilities are being divided. It's not only on the professional, okay? Like as you were discussing antibiotics, well, about antibiotics, okay, it's up to the professional to recommend it. But now for the actions that will help the patient get where he needs to be or she needs to be, we are talking about behaviors. And listen, the patient is the expert about his history and his behaviors and what he knows he will be able to do or that will not be able to do, okay? So this is a very important point because in lifestyle medicine, I think like the patient is here. We show this patient, this is where you need to get, but this long way is key to success. And when we see all these things and all these recommendations, or these changes that need to happen, we can be a little bit overwhelmed as well as the patient. So where do we start? How can we start? And well, science shows us that change is difficult, okay? This is a very, very complex problem that we can't solve with only motivation, okay, or only with professional orientation. Okay, so it's very important to link it to a vision. It is always important to know why you are making all these changes, why you are putting so much effort. So when I start talking about lifestyle medicine with my patients and to start creating this action plan, it's always good to have a direction. Where do you want to go? And I like to guide it through these questions. The first one is, who do you want to be when you get old? And I always like to ask this question to myself or to the professionals when I am training them, okay? Who do you want to be when you get old? And then I like to add the question, which stories do you want to live? Okay, which moments do you want to live? What really matters to you? And bringing it to a closer future, I always like to ask, and how do you want to be in 3 months? In 3 months from now, how do you want to be? Because everybody, or most of us, okay, we always have some complaints like, I am tired of feeling tired. Or, oh, I am always in a rush. I need to work so much. And then we don't have time to do things that are very important. And here we include time for self-care, okay? And when we talk about self-care, I will open here a parenthesis to mention that the role of the self-care of the health professional is huge. Science shows us that those health professionals who exercise tend to ask more if the patient is physically active, and the same for healthy food or for sleep, for many other behaviors. Okay, when we practice, when we do it, or when we are at least trying to do it, we tend to understand more the importance of asking if this patient does or doesn't do these things, okay? Next steps, when we are talking about changing behaviors with the patients, I like to ask this patient to make a list with What are you doing to make it happen? Okay, these things that you want to leave. And another list with what are you doing against it? This is a very important exercise because the patient can see and through his own answers, okay, what are his behaviors, where are his behaviors leading him? And the very important question here is, what are you ready to start doing? Okay, because as health professionals, we tend to know, oh my God, if this patient keeps eating like this, it will not go well. But in this case, we need to look for the open door. Okay, we need to look for what is this patient already ready and confident to do. Okay, this is very important because as professionals, we know which behavior or which action he should be doing first. But during this lifestyle medicine and coach approach, it's very important to take this in condition. Look for the open door, where it's easier for this patient to change, okay? I know it can be very, very uncomfortable sometimes for us health professionals when we see all these pillars and everything good that this patient can add to his life when he starts practicing it, that, oh, we want him to change everything or what we believe is more important. But please pay attention to this. There is something wonderful that is called keystone habit. And it's something that says that, it's a theory that says that you don't need to start doing everything at the same time. When you start changing one thing, it can reflect on the other. I'll give you an example, and maybe it happens to you, okay? You start being more physical active, so you start exercising more, and then you realize that you are sleeping better, or that you are making better food choices, or that you are less anxious or less nervous. Also, and the beautiful thing about lifestyle medicine and that this interaction between these pillars is very unique for each patient, but it's true. We change one thing when we see it is reflecting on many others. So we don't need to be on this rush, okay? What is very important is that this patient starts changing something, even if it's very small, even though it's better if he starts changing through small steps, okay? Because this patient will feel more confident, will think, well, I can do it. Okay, it's not that hard. And when you see, then you can give the next steps, right? Another thing that all the coaching works always say is that it's better to focus on one or two new actions, new habits, instead of trying to change many things. Because when we focus on one or two actions, the results are usually better, more consistent. And then you are ready to give next steps instead of spreading the energy and not being very successful in any. Okay. All right. Another very important point, so that I mentioned here. Instead of trying to climb a huge wall at once, okay, with a big challenge, it's wiser to divide it into smaller steps that will lead you to that very same way, okay? So it increases this feeling of self-efficacy. You feel more confident and you are doing things that are really, really meaningful to what you are trying to do, okay? But these small steps. And these small steps, I think they are key to lifestyle changes, okay? What happens is that when we are talking about how we can influence patients' behavior changes, it's important to not be just one appointment and then I see you in 3 months or even next month. No, at the beginning, it's good to see this patient more frequently, okay? Because he's starting to learn how to navigate through this new life, this new lifestyle, okay? So these more frequent appointments, they are very important. So what do we usually do? Okay, so this patient sets a small goal for the next week. So during the next week, we ask, how was your experience with this goal that you set to yourself? And then this patient will bring you what worked, what didn't work, okay? And at this moment, it's very important that we are open to receive the truth, okay? Because if we start getting too angry or too nervous, if we don't help this patient see and analyze what didn't work, we won't be ready to give the next step, okay? So it is good when we listen to from the patient. Oh, I did it, great, so let's build the next step. But I think the most important part here is, oh, doctor, I'm sorry, it didn't work. I wasn't able to do it. And then you try to discover why it didn't work. This is the moment where the magic of behavior change starts happening, okay? But anyway, I always like to mention this, to highlight that lifestyle medicine is not a checklist, okay? It's not a checklist of, I had 5 portions of fruits and vegetables, I slept 8 hours, and all these recommendations that we give, okay? Of course, they are important. And of course, some gadgets are really useful, like smartwatches or other things that help us keep track of, oh, I am not sleeping as well as I thought I was sleeping, or, oh, well, I am not as active as I thought I was, or, oh, well, I am doing better, great, it's good. But these need to be tools to help this patient be more engaged, not forget, okay, the things that he needs to do, but not as something oppressive, okay, not as something that will bring more stress to the patient's life. I always like to say that lifestyle medicine on its ideal model is what happens in the blue zones. Okay, the blue zones are the areas where patients, where people live longer and better. And they see that there people naturally move more. People naturally have this feeling of belonging to the right tribe, okay, having social connections. They naturally eat wisely. It's not because they saw it on social media that this kind of food is better. No, it's from their culture, okay? It all makes sense to them. But we don't need to be born in Okinawa or in Loma Linda or in Sardinia, okay, to live longer and better. It's always good to think about how to create your own blue zone, okay? Thinking, how can you make the healthy choice, the easy choice on your daily routine? Because we know the truth. It's not easy to change. It's not easy to bring new habits, even if it's with all the promises that lifestyle medicine brings to our lives. So it's very important to align with the patients. And I like to do it at the very beginning, okay? It won't be an easy way, okay? Like a straightforward way. Lapses, which are the moments when you return to the old habit for just a moment, they will exist. So it's good because the patient feels less failure when it happens. Because when we feel failure, we say, oh, I was not born for this. No, I can't do it. No, I was not born to eat this way. No, it happens to everyone. Okay, the secret is, okay, you had a lapse, just come back, go back on track. Okay, what do we learn from this moment of lapse? But come back to your track. But relapses are part of the process too. And relapses are the moments when we fall, when we go back to the old habits and we can't come back. It's so hard to come back. Imagine this is the moment where the patient will not be following your instructions. And it will be really hard for him maybe to say, oh, doctor, I failed. And this is the moment when he needs us the most, okay, to understand, okay, so what happened that led you to this relapse, okay? But remember, you were not alone. I told you that this would happen, okay? And we are here to find your way back to your track, to our old plan. And something, wow, that is really hard to deal with is craving. When you really, really want, when you really, really desire, you desperately desire something that can be a cigarette, can be alcohol, can be a chocolate, a toxic relationship, whatever it is. When you are craving and it's something that you say, oh my God, I can't keep having all these feeling, okay, I need help. An important information that usually helps patients a lot to deal with cravings. Cravings are not like a plateau. Cravings are like waves, and they usually last from 5 to 20 minutes. Okay, so this horrible feeling will not last forever. So find a way to deal with this craving wave for 5 to 20 minutes. So call someone, find another healthy way to deal with this thing. Ask for help, okay? But to know that it will last from 5 to 20 minutes is something that gives hope for this patient, and to know that it will pass, okay? Because in fact, our brain doesn't like changes, okay? Every moment that we need to change, it consider changes as threatening, okay? So we must go easy on it. Maybe including these smaller changes with pleasant changes, okay? Are adding positive emotions to this patient when he's doing this change. It's very important. And another important thing about the brain is we cannot change without increasing the complexity of our mind. What? How can I increase the complexity of our mind? How we can do it? We can do it facing these technical challenges and the adaptive challenges. What are these technical challenges? Well, technical challenges are things you'll need to learn to do, maybe to learn what is a healthy diet, or to learn how to cook, or how to start running. Okay, it's something technical, it's something cognitive. Another cognitive, however, so much more trickier, are the adaptive changes, okay? And the adaptive changes is everything that needs to adapt in our mind, in our bodies, in order to make it happen. Things like, why do we do what we don't want to do? Because we always think of the bad habits as something that are useless, but no, we have the bad habits because they are adding something to our lives, okay? For example, the pleasure of smoking, or the chocolate that feels like a hug, so many other things, okay? So we need to look at which are the hidden benefits of doing this bad habit that we don't want to do. We all often try to forget about it, pretend it doesn't exist, but it's bad, okay? Because when we think about these questions, including what are you secretly protecting when you do it, is these moments gives you new perspectives of your bad habit, and it often helps you to find blind spots that could become future traps on your desired changes. So it's important to look at these things too, all right? I know our next speaker will be Dr. Rob Lawson, and I love this initiative that they made at the British Society, which is called My Number One Change. And I used it here and on this card that I created, which is like a small guide to help us when we are making this action plan with the patient. So my change number one is, it is important for me to change because I guess I do this undesired thing because, and I will helpfully deal with it by, this is a good card to give for the patient to fill. On the next days, I am ready to, which obstacles might appear, what must happen to make it work, who can help me, and how will I celebrate this achievement? Okay, because we really need to celebrate. So, going to the end, to master the end of influencing patients' behavioral changes, we must practice a lot. Like any other art, it needs practice. It's not just talent. Okay, we need to learn these techniques and put them into practice. We must be sensitive. Listen, this is a position that is sometimes new for many of us health professionals. Use the health coach tools. Be curious about how this patient works, how this mind works, and connect. Okay, it's not just prescribe and deliver it. No, we need connection to help these changes appear. Okay, and always remember, the patient is where he is not where we want this patient to be. Okay, and respect that. It's useful to break the all or nothing belief. Okay, because or I am doing my diet perfectly, or okay, forget about it. No, remember, imperfectly done is better than not done. It's important to balance kindness with firmness, because lifestyle medicine is dose dependent. And if we let this patient spend too long on these doses, it may be harmful for him. So gently help this patient get there. And be the example, not an example of perfection, because, well, only a few people might be perfect, but we must be an example of commitment to these behaviors that will add years to our life and life to our years. Okay. Thank you so much for this invitation and for being here with me. Shukran jazilan.
Thank you so much, Dr. Slay, about this very interesting presentation. And now we will receive any question or comment.
Thank you, Doctor. I think maybe it's 3:30 in the morning. So thank you for being with us all during your sleeping time. Thank you for this excellent presentation. We'd like actually here in Saudi to know your experience in Brazil in lifestyle modification, and do you have like associations or groups, or how do you success actually in lifestyle medicine there in Brazil? Thank you.
Thank you very much for your question. Yes, I did the international certification in Tucson in Arizona in 2017, which was the first certification cohort. And I called other doctors who were interested in lifestyle medicine, and we've created the Brazilian College of Lifestyle Medicine, because I don't know how it happens to you, but here in Brazil, the name lifestyle medicine was being used for many things that were not actually lifestyle medicine. And we were very concerned about it. So created this organization, nonprofit organization, to put together the health professionals who were interested in learning more about lifestyle medicine and practicing it. And then I created the Exposed Graduation Program in lifestyle medicine, which now we have more than 200 doctors. Our association has, I think, about 800 or 850 members. So we are growing. Brazil has a very favorable field for lifestyle medicine because we have lots of fruits, vegetables, legumes. People like to make physical activity, but not all of them. We have still a high percentage of sedentarism here, but all these pillars are being very, very supported here in Brazil. So it's good. So it's a good field to have more professionals doing it. And we have many hospitals and we have many clinics applying lifestyle medicine nowadays. And it's good because we could break the first level, which was, lifestyle medicine is about well-being. Okay, and now we can prove that no, it's not just about well-being, but it's about it's clinical, it's a treatment. Okay, it helps you in some cases reverse diabetes. You can de-prescribe many medications when you start practicing lifestyle medicine, but most importantly, we see the patients more empowered, more confident, like those grandparents who were there sitting on the couch, and suddenly the family says, where was this person? Okay, because this is now an old man that goes dancing, that sings, who is alive. So I think it's very good to see. And another victory that we have is that now we are getting to the public service. And this is something that we really wanted, because it was seen as something for only rich people, for those people who could pay. But no, lifestyle medicine is for everyone. And so we are happy to say that now we are reaching the public service too.
Thank you so much, Doctor.
This is Salih Al-Raji, Dr. Slay. I talked to you over the email, which is very nice to get in touch with you. I'm really appreciative of you being here with us today, and appreciate the Brazilian experience with establishing lifestyle medicine. We started in 2018. We're slowly growing, and this is the biggest conference we have. And just to let you know, the community is all involved, and the conference has a big impact. And I'm just, like we talked on the email, probably we'll have more collaboration with the Brazilian Society of Lifestyle Medicine. And one of the proposals for this year is, or next year actually, is to have one conference for each province every month. And the crown would be in Hail again next year, inshallah ta'ala. So hopefully you'll be with us, everyone. So be ready once a month. Thank you, Dr. Slay.
Excellent, congratulations.
Another question, Doctor?
Thank you, Doctor, for your time, and we appreciate that it's really late there, but your talk was really wonderful and practical. This is what we like about. I like what you talk about keystone habit, which is really important that when we discuss with our patient to explore habits and the keystone habit that we can start with. Also to normalize lapse and relapse, and this is very important, as you mentioned before. The patient said, I did what's supposed to be, I didn't, it's okay. So this is very important, normalize and empathize with the patient and let them have their own plan B. And this is what we are doing in the clinic. Make the patient design their own plan B. So if this not happen, what you will do? If you travel, for example, if you go to gathering anything and you cannot follow our instructions, what other plan B that you can do? My question regarding that, if you have any special training or workshops regarding coaching there in Brazil, or you are following a specific strategy. Thank you so much.
Thank you for your question. Yes, the first contact that I had with lifestyle medicine was in Harvard, but I felt like, okay, there is a part missing, and I discovered that it was the coaching the health and wellness coaching. So I did this formation here in Brazil with a wonderful woman who was Margaret Moore's student. And since then, when we started this post-graduation program, the name of the post-graduation is Lifestyle Medicine and Health and Wellness Coach, because I cannot see lifestyle medicine happening without this coach approach.
Thank you so much, Dr. Slay. We have another more question, and the online audience, please, if you have any question, please raise your hand.
Thank you, Dr. Slay, for this great presentation. It was heartwarming, actually, because we see this experience actually in our clinics when we have that conversation, especially when I worked in the smoking cessation clinic. I would like to take this opportunity to explore your practice from administrative point of view, who deliver lifestyle medicine clinics, and how patients or clients land into that clinic, and who pays for that?
This is the $1 million question, right? It's challenging to everyone. Patients come to the clinic. My patients who were my old patients, I started practicing lifestyle medicine with them and they loved it. So they were talking to other people and people were coming. But I also made a work of telling other doctors and other health professionals about lifestyle medicine and about the work we do at the clinic. And they started sending patients because usually an endocrinologist, a cardiologist, sometimes they don't have the abilities or patience to do all this process with the patient, but they know it's important because they know that just saying you should eat less and exercise more doesn't work. So they felt like relieved to have a place to send their patients to do this important part of the treatment. At the clinic, we have private patients who come and pay for the service. So we make some programs of consultants, physical activity evaluation, nutrition, and they pay for this package, including this follow-up, okay, with the health coach. We also have patients who have insurance that pays for the nutrition, pays for the doctor, so they use insurance to do it. And for the public service, it's going to be related to the government, but we are trying to make some public-private partnerships, okay, to have companies paying for this service and without having to pay so many taxes. So this is something that has been working. Oh, and another project that we are doing now is we are treating doctors. So we are health specialties, medical specialties associations are calling patients who are health professionals, okay? So for example, for the Brazilian Society of Anesthesiology, they are inviting anesthesiologists who want to go through this lifestyle medicine process. And we have pharma companies paying for it, being sponsors of this project, which is interesting. And I like to report that we don't have contact with the pharma company, okay, the pharmaceutical. So we don't have bias of, oh, we were going to say this or that. No, we are free to say whatever we want. They are just offering that service to the professionals.
Thank you so much, Dr. Slay. It is nice to hear from you this very nice topic. And I think all the audience was glad for hearing this very nice and very interesting and formative lecture. and we hope we meet again, inshallah, in the next conference in Hail, inshallah. Thank you so much, Doctor.
Thank you so much. Have a good day.
You too. Our next part of our session today, we make a small change in the schedule. And now we will hear from Dr. Nasreen Mubarak, our famous Dr. Nasreen. Dr. Nasreen will talk about the epigenetic and the lifestyle medicine and the modifiable chronic disease. And I think it is also very important topic today. Let's welcome Dr. Nasreen.
Thank you so much. Assalamu alaikum. Good morning again. You took a breakfast or not yet? Now we're going to talk about little bit heavy topic. It's called talk about epigenetics. So I will start first with this question. Is your gene your destiny? And we're going to answer in the end of the lecture, it's or the end of the talk discussion. Is it yes or no? But in the beginning, I need to see hands. Yes? Who's saying yes, your gene is your destiny? Okay, 1, 2, 3, 4, 5. Only 5? Okay. Let's start by story. This happened in 2005 in Madrid. They took almost 40 pairs of identical twins. The age group was a little bit wide. They start from 3 years and including up to 75 years. And they study the lifestyle of these identical twins. So identical twins means same genes, right? So they study the intervention of the lifestyle of these identical twins in starting from 3 years and in each age group till they reach 75. What the effect of their lifestyle on epigenetics and the epigenetics effect on gene expression? Okay, these researchers found that 4 times the epigenetic changes as many differentially expressed genes such as lymphocyte, epithelial, and abdominal fat cells at pairs of 50-year-old twin compared to 3-year-old twins. And this is parallel to lifestyle habits. And this is little bit give us a clue if there is really effective, good effect of lifestyle on the epigenetics and genetics. It's the result of this study was 4 times the epigenetic changes in 50 years old twins. They are not living same lifestyle compared to 3 years old living same lifestyle. So there was significant effect of lifestyle on epigenetics and on gene expression. So our outlines today are going to talk about why physicians have to know about epigenetic changes, define genome, chromosome, telomere, some definitions in genetics. What is epigenetics and epigenome? Epigenetics process and little bit implications from reality. So why physicians have to know about epigenetic changes? Because physicians dealing with health and disease. And if you know what's the causation and association of disease, you can interfere as early as possible. Also to deal with lifestyle habits and behaviors seriously as real drivers for the epigenetic changes and genetic expression and on disease. To use the magic of lifestyle habits as drivers of health to reverse the disease. let's revise some definitions. I know this is old and from medical school, but we'll try to make it simple. Genome scientists, usually they are make it as library. It's your own library. You're taking 50 from your father and 50 library. Chromosomes, as you are seeing here, we have how many chromosomes in our cells? 46, okay? And the chromosome structure is 2 chromatides. We have long arm and short arm, and centromere in the center, and the telomere in the end. And telomere now have a lot of studies regarding telomere for aging process and disease and all this. So we have the nucleus and we have chromosome inside and we have DNA inside the chromosome. DNA have 4 bases: adenine, cytosine, thymine, and guanine. Let's see genotype and phenotype. Genotype, if we have, for example, mother with blue eye and father with brown eye, and blue eye is small b and brown eye is a capital B. And we're gonna make small b and capital B for brown and 2 small b for blue eye. The 2 small b, it's genotype. So this is the genotype of blue eye. But if I ask you about phenotype of blue eye, you're gonna tell me that it's a blue eye. So phenotype is the observable description of the genotype. Okay. So what is epigenetics? What's the meaning of epigenetics? Epigenetics, it's any process that alter gene activity, okay? Lead to modification and changes at gene expression. So it's changing the gene expression, but not DNA. So it's not changing your own DNA. You're doing your own DNA, it will be the same, but the gene expression will gonna be different. Okay, epigenetics, most of studies show that it's reversible process. And from here, we have a lot of implications regarding chronic disease, cancers even. We're gonna discuss with you today, even prostate cancer. There is a lot of studies was done since long time, and they do a huge project to make epigenetic mapping as genetic mapping. And it's have a lot of sectors actually, and a lot of countries. They act together to do this epigenetic mapping, and they see that they have a lot of epigenetic processes, but the most process was well studied. These 3: it's DNA methylation, histone modification, and non-coding RNA. And the most important that to remember that epigenetic processes are natural and essential, and this is happen daily basis. We are a human being. We are act and react. So if you have, for example, hot weather, what will gonna happen with you? Cold weather, if you are living in high altitude or low altitude, you are reacting to the environment, and this is gonna make epigenetic happen in your body, natural process. Okay. DNA methylation means, as Dr. Saleh said, that I like this DNA methylation, like gene off. Okay. And for example, if you are talking about, I'm going to explain to you in atherosclerosis now, but if the methyl group attached to cytosine base, this will gonna make this part of DNA inactive. So there's no expression, gene expression in that part of DNA. This is what happened in DNA methylation. So that, as you can see, this part of DNA, it's off, is not working. This is one example about this genomic imprinting. We have 2 kids here. The kid first one is Angelman syndrome. Both of them, 46 chromosomes, normal, everything is fine. But if you see in chromosome 15, the maternal part of Angelman syndrome is not working, it's inactive. So that make Angelman syndrome have different characteristic with this shape. On the other hand, Prader-Willi syndrome down here in same chromosome, it is not working, it's inactive. So this make Prader-Willi syndrome different. So this is the magic of genes and epigenetics. As you are seeing, it's inactive, make you totally different characteristic of two totally different syndromes. This is DNA acetylation. Acetylation in here, in the other part, I don't know, pointer is not working. If epigenetic factor, for example, physical inactivity, fatty food, cancer, disease, whatever, it's called epigenetic factor. Attached to histone tail in the DNA that make this part of DNA active. So this is the different process here. And you can, like you are saying, this part of DNA, it's on and it's have a lot of gene expression in this part. Let's see how we can apply it on atherosclerosis. Atherosclerosis, as all of us know, it's inflammatory process. And it's starting with what, if you remember? First thing happened in atherosclerosis. It's endothelial injury, right? This is first thing happened. And according to that, platelet aggregation and all this happened to close that artery. But with epigenetic study, they found that there is something called oxidized LDL. Oxidized LDL is accelerating that DNA acetylation in the endothelium in that part, so the monocyte can pass through the endothelium easily and swallow the oxidized LDL and make foam cells and close the artery and causing atherosclerosis. So epigenetic here is aggravating by epigenetic factor, it's oxidized LDL. Okay, so oxidized LDL, this is our enemy here. What can increase it? This is very important epigenetic factor, by the way. Causing by dyslipidemia, insulin resistant, hypertension, abdominal fat, and abdominal obesity, and obesity and overweight in general. Okay, this study called Geminal study. This study studied the prostate cancer, low-risk prostate cancer, and the effectiveness of lifestyle intervention on epigenetic and gene expression of this prostate cancer. Is lifestyle intervention really can stop prostate cancer progression or even do downregulation of gene expression of prostate cancer or no? So this is what the objective from this study. It's prospective single-arm pilot clinical intervention study in 30 men and with low-risk prostate cancer. All of them was diagnosed with biopsy and with PSA. Duration was 3 months of this study. Measurements for every patient in the 30 men was PSA, C-reactive protein, and prostate needle biopsy to confirm the diagnosis, weight and height and BMI and waist circumference, triglyceride, and serum lipids and blood pressure. Inclusion criteria was mean age of 62 years old from 49 to 80, biopsy confirmed prostate cancer, PSA less than or equal to 10 to make sure it's not active prostate cancer. No surgery or radiation was received for these patients, all of them, and Gleason sum less than or equal 6, and that means it's not well differentiated cancer. No, it's low risk. Okay, what are the interventions? What happened with these patients? So we are seeing we want to study the lifestyle intervention on the prostate cancer expression. Stress management, psychological group support, moderate intensity exercise, whole food, plant-based, low-fat diet, and score of SF, it's quality of life 36. It's comparing in pairwise fashion each man's biopsy. So they was comparing same patient biopsy before and after the intervention. And this is give a strength for this study. It was 3 months follow-up with serial biopsy from the prostate. With this, so that was shocking actually. Pre-intervention, there is red color that you are seeing here. That means it's upregulation of prostate cancer. On the other hand, post-intervention, the green color, it's downregulation of the prostate cancer. And this is only 3-month intervention. Total PSA didn't change significant, but free PSA was improved significant. And we know that free PSA is the highest indicator for progression. Also significant improvement on BMI, systolic and diastolic blood pressure, lipids, and waist circumference for the patient. For triglyceride and C-reactive protein was decreased also. Quality of life was improved, especially mental component. Okay, so when they found this result, they was curious to know about telomere, because these patients having same lifestyle intervention, and there is big improvement within 3 months. So they decide to follow same patients for 5 years to see the effect of lifestyle intervention on telomere. Okay, so as we explained before, telomere is the end of the arms of the chromatides of the chromosome, and they want to see if it's become shortening, become elongating, no change after 5 years of lifestyle intervention. So between 2003 and 2007, from previous study, men with low-risk prostate cancer, this descriptive study investigate the effect of lifestyle intervention on the telomere. Intervention group was 10 men from previous study, same criteria, and control group was 25 external control with low-risk prostate cancer also. And our intervention group, comprehensive lifestyle intervention. In the control group, it's active surveillance only. And after 5 years, if you are seeing here, this red, orange color down, representative the control group. So the control group, the telomere was shortening minus 0.3 after 5 years. Compared to the interventional group, the telomere was not only staying the same, it's become elongated up to 0.06 other than the baseline. So in this small pilot study, after adjustment for age and length of follow-up, significant increase in relative telomere length. The recommendation was we need larger randomized control trial are wanted to confirm this finding. So at the end, I want to tell you that, as we say before, we need as physicians to realize why we are really caring about lifestyle intervention, because it's not only changing or reversing disease, it's changing the epigenetics and gene expression in your body. And if there is any progression for any disease, it can really be reversed and can be stopped by evidence, even on level of epigenetics. These are my references, and big acknowledgement to my colleague, Dr. Widat Fallata. She is human genetic special consultant. She helped me a lot on that talk. And usually I'm saying الحائل بعد حي. This is, we learn it from you, and it's very beautiful. Thank you for everyone. This is my contact, WhatsApp and email if you want to ask about anything related to coaching or epigenetics. I'm so interested and passionate in both of them, and in anything related to lifestyle. You have a question? No.
Thank you, Dr. Sri.
Excellent presentation, Dr. Nasreen, an overview of epigenetics and genetics. I think we need to do more studies on this in the next year or two, inshallah ta'ala. Are interested. This is repeat to previous announcement and a little bit of addition. أظن كلنا نتكلم عربي. بدأنا احنا مشروع كتاب الله لايف ستايل ميديسن سعودي لايف ستايل ميديسن تكست بوك. فأنا أقول للزملاء والزميلات اللي عندهم استعداد ونحيي الدكتور خالد الجابر توين حياك الله دكتور. ف we'll be calling people by name and those who are interested please let me know. اللي يدري يعني يعطيني خبر. الشيء الثاني بيصير نبي نبدأ ننشئ مجموعة اللي هو lifestyle medicine clinical tools. Could be forms, it could be others. And this is, we need brainstorming in this عشان يناسب البيئة اللي احنا فيها، يناسبنا احنا. ما كل شيء يناسب الدول الغربية راح يناسبنا. هذا يروح مع الفكرة انه لازم احنا نشتغل على او الان نعمل يعني فعليا على معرفة ما هي البارامترز والاشياء الطبيعية لنا من ناحية السكر والضغط وغيرها من الاشياء الاخرى. شكرا.
Thank you so much, Dr. Saleh. Any question for Dr. Nasri? One question.
السلام عليكم دكتور نسرين. أول شيء أشكرك على هذا التوك معك دكتور محمد الحقباني Family Medicine. I think epigenetic is the future of our medicine because as you say, even if you have gene, if it's not expressed, the disease will not manifest itself. I think genetic editing, genetic repair will be the future of all medicine, especially epigenetic and its relation to aging and disease. Also, but I want to ask you about several things. Is there, how can we apply epigenetics to our clinic? Is there a way to measure the epigenetic changes that's happening in the body? And what is the best lifestyle modification to improve epigenetic profile in our patients? Thank you very much.
Thank you, doctor. This is an important question, actually. This type of information, it's important for us as a physician to believe more on lifestyle intervention. So if you explain to your patient that if you're doing exercise daily basis within 3 months, this is gonna happen, depend on a scientific evidence. This is gonna make you more strong when you are really explain to your patient. If you are promising your patient, if you decrease your weight, I can decrease your medication, for example. This also gonna make your information more valid. For this second part of your question, that if you have how to measure epigenetic changes, actually this is purely genetic work. So you have to have a lab, genetic lab, and they are the one who taking, because in this study, they are taking biopsy and they are measuring the genetic upregulation and downregulation, and this is happened in lab in very specific manner. I think, up to my knowledge, we have genetic lab in Riyadh, but I'm not sure where. It's a specific labs for this, but it's a great to have this move, as Dr. Saleh said, if we can do something, because they are you see, it's only taking 30 patients, 10 patients with a specific characteristic, and will be under sponsored with someone. Will be great if we have our own evidence here in Saudi Arabia with clear epigenetic changes. But for everyone, yes, lifestyle is affecting epigenetics and genetic expression, and you can see that in your patients. One of my patients, after 3 months of decreasing almost 10% of her weight, When she come to my clinic, I see her face, she's younger. Really, I tell her, you are younger. You are not the one who come to me before 3 months. So you can't see this in your patient, but we need to have a scientific evidence. Yes, you are right.
Thank you so much, Dr.
Just if I want to tell you, if there's no more questions, regarding the coaching, who's interested in coaching, I'm certified as advanced coach. So I have workshop in March. If anyone interested for that, they can contact me. On my contact, we can send you details. Okay.
Thank you so much, Dr. Nasreen. Thank you for our speaker for the second session and for you. And let's start our next section with our the moderator of the next section, Dr. Ahmed Al-Afnan.
Thank you all. Welcome to the third session for today with Dr. Khalid Al-Jaber. He will discuss the power of social connectedness. Dr. Al-Jaber is a consultant in family medicine at National Guard in Riyadh. Help me all welcome Dr. Al-Jaber.
هذا لازم امسكه ذا ولا شنو؟ ما في هولدر؟ طيب بسم الله الرحمن الرحيم. السلام عليكم جميعا ورحمة الله وبركاته. Is anybody who can't speak Arabic? You can't speak Arabic? So then learn it. Okay, so I will just أحسن والله. صوت واضح؟ طيب I will just start by a small story yesterday in Arabic. البارح اللي استقبلون تحت قال لي متى خمر جيت حائل؟ قلت هذه أول مرة أجي حائل. ناظر بحرت سيدا ناظر. قال أول مرة تجي حائل؟ قلت إيه؟ قال قاعد تزين طول عمرك أنت. أنا من أول حسبنا إحنا أهل عنيزة إحنا الوحيدين اللي نحب عنيزة إلى هالدرجة دي الإدمان. طلعوا هالحايل وين تعدونا بالحيل ها؟ طيب. Today I have two lectures. You know the الأركان الستة اللي lifestyle, the 6 pillars of lifestyle. 4 of them are maybe neutral cross cultures. But 2 of them are culturally very sensitive culturally. The one with relation, the other with the stress management. And I think it's a bias that they put the logo of yoga in the stress management. Maybe it's acceptable in some cultures, but it's not acceptable in every culture. So my 2 talks today, one is about the relationship and the other one is about stress management. The afternoon, inshallah, about the stress management. I will try to explore other views about how we see relationship efficacy in lifestyle and in health. How we see it, and is there any different approach in seeing relationship efficacy in lifestyle in general and in psychological well-being in general. My background is I'm a family physician, but for the last many years I was practicing psychotherapy, mainly CBT, cognitive behavioral psychotherapy. And this is why I'm really interested in these 2 areas in the 6 pillars of the lifestyle. Social the power of social connectedness, the relationship. Yes, there is no pointer. What's my argument here? My argument is that the quality of relationship is very important. The quality of relationship with people affects our psychological health. And the quality of relationship, how we relate to others, the quality itself, the characteristics, of how we relate is highly culturally sensitive. And it varies among cultures. And this is why I'm trying to explain how we could add to this science by from our own literature. I will divide. I think there's a missed slide here. I will talk about 6 or 5, I think, or 7 groups of characteristics about in relationship. مجموعة من الصفات أو الأخلاق أو الطباع التي تؤثر على جودة العلاقات بين الناس. مجموعة من الصفات أو الطباع التي تؤثر على جودة العلاقات بين الناس. How it changed the quality of relationship. Most of these are taken from my own experience in the clinic and the consultations and in the courses, workshops in the community, and from Arabic and Islamic literature. Justice and injustice, rights and duties and responsibility. The issue here is that if the relationship between people are based on justice, based on performing rights, duties, and responsibility toward others, and based on stop hurting people, this is number 1 quality in relationship. In a clinic, one of the major reasons of depression, anxiety, and others is a poor relationship, poor quality relationship. And one of the major reasons, this is why I started with it, many of the main reason why poor relationship is injustice. الظلم اللي يصير بين الناس والعنف والأذى والقسوة اللي تصير بين الناس مع بعضهم مع بعض تؤثر كثيرا على العلاقات وتؤثر كثيرا على الصحة النفسية. And عندنا course, we have a well-designed course, in this area, relationship, how we could improve the quality of relationship between people with a lot of exercises and daily life practical skills. What I noticed that from the clinic and from the consultations that people are really suffering from toxic relationship. And toxic relationship is not only somebody who is drug addicts. No, he may be a very fine CEO. He may be a very fine, excellent, successful businessman, but he has a very poor quality relationship with his wife, or with his husband, or with other members of the family, or friends, or neighbors, or relatives, or whatever. So this is number 1 characteristics of quality of relationship. Number 2, أنا ما لقيت ترجمة لها بالإنجليزي، اللي هي سلامة الصدر. في مصطلحات كثيرة بالعربي ما لها معنى مقابل حرفي بالإنجليزي. سلامة الصدر، لأنه أصلا مفهوم الصدر مفهوم عربي، ما هو مفهوم أجنبي أصلا يعني. فسلامة الصدر, chest integrity and mutual emotions. في نقطة مهمة ثقافية هنا، ترى لو تلاحظون مثلا حتى في اللايف ستايل ميديسن لما يتكلمون عن ريليشن شيب أول شيء يتكلمون عنه إيش؟ love. هذا انعكاس للثقافة الغربية. مو بشرط إن love is always number 1 in every relationship. هذه نقطة مهمة من اختلاف الثقافات. أصلا حتى مفهوم اللف، مفهوم الحب أصلا مختلف بين الثقافات. فاللف، لكن الحب مهم جدا. love and hate, envy and hatred, cunning and maliciousness, الكيد والمكر والخداع, jealousy, الغيرة. Again, from my own experience in clinics and courses and consultations, people suffer from dysfunctions in this area. Either from a side who is really dry in emotions, or very important, from the other side who is asking for more. High level of تعرفون احنا في العلاج المعرفي السلوكي in CBT دائما لما يجينا المريض ما نصدقه على طول، لازم نتاكد انه what he's saying is it real or not. فاحيانا كثير يطلع كلامه مو بصحيح، يطلع هو عنده مبالغات، هو يطالب بمشاعر عاليه جدا. He is requesting high level of emotions from others. he is requesting، وخاصه الان يعني مع يعني الزخم اللي جالس يصير في الميديا في موضوع الأهمية العاطفة، وصار الناس بس they're craving for emotions. They were craving for emotions. This is not healthy. What will happen is that we will find a lot of people, increasing number of people who are craving for supportive emotions, high level of supportive emotions. They will not find it and they will have depression. And the reason for this is from the starting point, they don't define correctly what is the needed level, really needed level of emotions, psychological support and family support. And yesterday, a very wise and educated woman with depression, her main problem that my husband is not giving me enough emotional support, and she is depressed. We as a CBT, we usually don't believe patients' words. We investigate. In CBT, we always investigate, and we encourage patients to investigate. Is this really right or not? And then on the middle of the session, she said, well, I realized that I'm asking for more than what he can give. I'm asking for more than what he can give. So balance in emotions is very important from both sides. From me to give emotion for others, but from others to expect a right level of emotion is very important also. Kindness and mercy, cruelty and harshness and violence. It's related to the first one, but it's very separate because it's more practical here, where kindness, being kind and soft to others, الرفق والرحمة والعطف والشفقة, and mercy and compassion. بالمناسبة لما جيت أترجم باللغة العربية وجدت إنه مثلا تلقى مثلا مصطلح الرحمة، الشفقة، العطف في اللغة العربية يمكن 50 كلمة. In English, it's only 4 words, 3 words, or 5 words maximum. So you will find it very difficult to translate the real specific meaning of the Arabic word. خاصة في المواضيع هذه يعني اللي فيها العرب تكلموا عنها كثير جدا واطلقوا عليها. مثلا يعني كيف تفرق مثلا بين الرحمة والعطف والشفقة؟ كيف it's not an easy issue. المهم بس الفكرة يعني the idea is clear here that being harsh, violence. And now it's the media, I mean, mode of talking about the violence, family violence, home violence. But for me, I mean, violence is a very wide terminology that we have to define it very well and to look for after the reasons behind it and why violence is happening. And for example, my own approach in treating violence in families, I usually explain to the victims that you have to change the rules of relationship and the environment, so the other person, he find it very difficult him to become violent, or difficult or costly for him to be violent, because all the legal issues did not work very well in our community. So we have to find a way on how to stop this person from violating the relationship or being a toxic person in the relationship. Art of conversation, dialogue, and communication. How how you talk with others. What's interesting, I thought at the beginning of my research in this area that I would not find enough literature in Arabic literature or Islamic literature. But what I found that one of the major topics and chapters in Islamic literature, early Islamic literature, a lot of prophet says حديث كثيرة ونصوص قرآنية كثيرة وآيات قرآنية كثيرة تتكلم عن الحديث والمنطق والكلام وأدب الكلام. Then I thought of, okay, what if we study this and try to make it contemporary for nowadays? And I found it very easy that there are certain lists that we could coach or teach people how to conversate, to communicate with others in a proper way. Kind words, tactics, cheerfulness and intimacy, thanks and praise, reverence and respect, الاحترام والتقدير, mockery and sarcasm, الاستهزاء, backbiting and gossip, الغيبة والنميمة. I think if this area of quality and relationship is very important, it will improve the quality of relationship. في جملة وجدتها قديمة جدا للعرب، حتى أظن أيام الجاهلية بالعربي يقولون الكلام كلام. يلا حلوها، من يعرف الكلام كلام؟ تفضل. أي نعم، الكلام الجرح. الكلام كلام، كلام بالضم يعني جرح. So words can be very painful, very painful sometimes. Charity, public benefit, generosity and righteousness, الإحسان والبر. يعني I will say it in Arabic. لما تقرأ مثلا الكتب الإسلامية عن الإحسان والصدقة تستغرب يعني مثلا علماء دين شريعة وفقه وحديث يتكلمون عن القضايا هذه، يعني وش علاقتها؟ يعني هذه أمور إنسانية ما لها علاقة يعني كأنه ما لها علاقة بالدين، يعني هي أمور إنسانية وعطف على الناس ورحمة. لكن اكتشفت في نقطة مهمة جدا. شفت المحاضرة اللي قبل هذه لما كانت تتكلم عن البيهيفير تشينج، أنا كان عندي تعليق بس يعني الوقت ما كان يسمح. شوفوا ليش اللايف ستايل changes is almost very difficult. لو تلاحظون الابروتش حق الاستاذ اللي قال الدكتور اللي قبل شوي، احنا نسميه في البيهيفير تشينج، نسمي الابروتش هذا individual level approach. يعني نشتغل على الليفل اوف individual، نجي نمسكه زي ما سويت الابروتش حق اللي سويته، انه ترى يعني اول شيء empowerment لازم انت تسويه، وترى في خير منفعه لك وكويس وممتاز، وش الصعوبات اللي تواجهك وليش انت تبي وش ودك تصير والى اخره. كويس. هذا كله على individual level. لكن احنا عندنا تجربه، احنا 60-70 سنه ماضيه في الميديسن، وثبت انه if you work only in the individual level you will fail at the end whatever you do. So you have to work in another axis, a different axis, not only in the individual, because the individual, she said a very nice word, a statement at the end, that we have to make a healthy choice, an easy choice. And I usually say, we have to make a healthy choice, a normal choice. Not only an easy choice, a normal choice. يعني مثلا هي ضربت مثال البخاريين اللي في بخارى وما بخارى يعيشون 120 سنة، فقالت عشان المجتمع. لا، هو النورمال هنا، النورمال in that community. Normal in that community is to do this and that. So how to make the healthy choices normal, not only easy, to make it normal. So that means we have to work in another level. واحدة من الأشياء, one of the things that's very important here is to incorporate the higher level of concepts in the human being, So they can do things not only because of it will change the hemoglobin A1C and it will change the body mass index. No, because it is related to your view in the life and how you see life and what is life is for and all the things. هذا إن شاء الله بتكلم عنه أكثر بعد الظهر إن شاء الله. لما أتكلم عن إنه how we could change the game. Instead of just only working on the technical skills and the individual level, how we could work in a higher level of inshallah بعد الظهر afternoon inshallah. So here generosity, chivalry, nobility أو العكس meanness and villainy الندالة والخسة والبخل والتقتير والstinginess والى آخره. هل هذه, do you think these kind of characters affect lifestyle, affect relationship? If yes, will this affect the lifestyle? If yes, will this affect our health, psychological and physical? So this is the equation. What I argue here today is that if we improve the quality of relationship, not only just connectedness, the quality of relationship, if we incorporate the culture itself, the culture, we talk from the culture, from within the culture, not from outside the culture. We are not imposing something. No, we are trying to talk to the people from in the same level of knowledge hierarchy, culture hierarchy, and all the things. People will do it, inshallah, in a better way and a higher chance. في قصة مشهورة تدل على هذا، وكنت بذكرها بعد الظهر اليوم بس أذكرها الآن وأعيدها بعد الظهر. في واحد من قادة القبائل في عهد النبي صلى الله عليه وسلم، قادة القبائل في نجد، أظن في نجد، كان مسافر فمسكوه الدوريات الإسلامية، مسكوه ودوه للرسول صلى الله عليه وسلم. فلما دخل على النبي، في قصة حصلت مهمة جدا، لما دخل على النبي صلى الله عليه وسلم، الرسول صلى الله عليه وسلم شافه، عرف إنه رئيس القوم قائد القبيلة، ما سوى له شيء، قال خلاص خلوه في المسجد واربطوه في المسجد بس عشان بس يشوف المسلمين، بس يشوف المسلمين. أول يوم، ثاني يوم جالس يشوف المسلمين يصلوا، والرسول صلى الله عليه وسلم يخطب وما أدري إيش وكذا. بعدين جاء الرسول ثالث يوم قال خلاص روح لأهلك يلا مع السلامة. حركة تكنيك غريب يعني. الرجال طلع أقرب مزرعة حول المدينة، اغتسل وتروش ورجع وأسلم. قال أنا ما حبيت أنكم تقولون أنه أسلم عندكم عشان ما يتحدث العرب أنني أسلمت يعني خوفا أو ما أدري إيش. مو بهذه القصة. القصة أنه الصحابي اللي كان مسؤول، الجندي اللي كان مسؤول عن حراسة هذا، يقول كنت لما كان في الأيام الثلاثة الأولى كان مسجون، كنت أجيب له أكل يأكل أكل البعارين، يعني أجيب له نصف ذبيح ربع ذبيح يأكل. يوم أسلم جاء اليوم الرابع جبت له نفس الأكل، أكل شوي وخلص. استغربت، قلت له شلون أنا ما أكلت؟ قال خلاص يكفي. فذهب النبي صلى الله عليه وسلم يقول أخبره يا رسول الله الرجال كان يأكل أكل البعارين والحين هذا يعني بالعامية طبعا. فقال الرسول صلى الله عليه وسلم إن المؤمن يأكل بمعن واحد وإن الكافر يأكل ب7 أمعاء. إيش معنى هذا؟ What kind of change that could happen in this person؟ أنا أعتقد أن اللي تغير هو الليفل of change، ما هو بالليفل على individual level، لا هو فوق، هو أصلا خلاص أصلا معنى الحياة كلها تغير عنده. معنى الحياة كله تغير. The whole meaning of life change. The whole meaning of himself change. هذا اللي أقصده أنا، إنه if we work in the higher levels maybe the achievements will be more. وعندنا أمثلة كثيرة. مثلا أنا أذكر أول بحث سويته لما كنت ريزيدنت كان عن التدخين. عفوا مو بريزيدنت، أول ما تخرجت كنت مشرف على ريزيدنتس كان عن التدخين. فكنا نسألهم إيش الأسباب اللي تخليكم، مسكنا الناس اللي تركوا التدخين مو بالعكس، مسكنا الناس تركوا التدخين why you quit smoking. كان من أكثر الأسباب الدينية. كان من أكثر الأسباب إنه الأسباب الدينية كانت عامل قوي ل طيب أنا كويس على strength and weakness, arrogance, humility and authority. Level of relationship, level of authority between people. هذا دائما في العياده كثير مره، انا ما اعرف اخذ حقي، انا غلبون الناس، انا مظلوم، انا ضعيفه، انا ضعيفه شخصيه، انا وهذا يكثر في الرهاب الاجتماعي ويكثر في الاكتئاب، يعني في حتى في القلق موجود، حتى في القلق في الانكزايتي ديسوردر يصير موجود هذا. ف if we manage to improve this level of quality in relationship, how to make، طبعا ما نقدر احنا نخلي الناس كلهم اقوياء يعني، لانه الناس يختلفون في الطباع، في ناس لسانه هالطول وفي ناس يعني طيب وحنون، مو بلازم كل الناس يصيرون لسانهم طويل اصلا يعني بس ان الفكره وش الفكره؟ انه كيف تتعامل مع الظروف المختلفه، how to change it. Relationship is really matter, and what also matter here is incorporating the cultures and working at the higher level rather than just only individual behavior change. And thank you. ما ادري عادي اذا كانت المحاضره ان شاء الله ان المحاضره كانت مفيده، انتم ضحكتوا، اكثركم ضحك، ما ادري عاد ضحت يعني.
ثانك يو دكتور خالد حقيقه فور ثانك يو which was حقيقه reach to the every aspect in our life. Any question?
شكرا دكتور خالد. Nice presentation. I think we have to dig deeper into this. هذا بس حنا لمسنا السطح الحين. بالنسبة لسلامة الصدر, I think the right translation is probably intention integrity. يعني لها علاقة بالنية هي, ولا علاقة بالemotions شوي, emotional integrity. لكن النية يمكن أقرب, لأنه لو اسمع أقرأ واحد إنجليزي ما راح يفهمها. فيمكن intention integrity is closer to what you want. I know بالإنجليزي اللغة العربية ما شاء الله تبارك الله يعني تقدر يعني ألذ وأحلى وأشمل لغة في العالم.
يا بعد حي.
إيه والله. اللغة الإنجليزية it's limited. So in order to يعني إذا بتشرح شيء تتعب وتشرحه. هم يعانون منها. فاللغة العربية أنا أتوقع أنها هي أفضل لغة لحمل العلوم, لأنها تستطيع تشرح الأشياء بشكل سهل, وتستطيع أنك تتوسع بالمعنى أو تضيق المعنى حسب ما تريد يعني. لكن أنت I think intention integrity probably the best choice.
I will think about it. جزاك الله خير.
شكرا جزيلا دكتور خالد. دكتور خالد is my trainer. I'm really glad that you are here, and I like your way of approach. It's totally taking our history, our culture to the practice, instead of just keep relying on whatever coming from the other civilization. سؤالي بقوله بالعربي, أحاول أترجمه بالإنجليزي. العلاقة المجتمعية اللي تحكم المجتمع بشكل عام, لو أخذنا يعني صورة خلينا نقول من هليكوبتر, المجتمع في الفترة الأخيرة متجه باتجاه التعاقدية البحتة, بناء على الثقافة الغربية المنتشرة والمادية مبنية على العلاقة التعاقدية زي ما يسميها الدكتور المسيري, مقارنة بالعلاقة التراحمية. فانعكاس هذا على مستوى مجتمعي, على المستوى الأفراد والعلاقات, أتمنى تعليقك عليه. So in translation, my question is about how can we look for the relationship base in a manner of what is there in the community through materialistic civilization that looking for all relationship on a contract base instead of merciful based, if it's the correct translation. شكرا جزيلا.
الله يرضى عليك, يعطيك العافية دكتور. Yes, it's part of the what they call it individualism. الفردانية, individualism where the individual is the center of everything, and so he by the way, يعني lifestyle now is individualistic because it only talk about the individual himself. in relationship, all the seven chapters of characteristic that we just mentioned is their own main target and goal is to change this from individualism. لذلك احنا وش نقول? For example, in psychology, they always talk about self-assertion, assertiveness, self-actualization, self. لكن في المنظومة الأخلاقية الإسلامية ما في هذا، غير موجود. شو اللي موجود؟ موجود حسن الخلق، موجود الأخلاق الحسنة، موجود التعامل الحسن. لأنه إذا أنت، وهذا ذكرته أنا كثير في تغريداتي في محاضراتي، إذا أنت تضرب كثير على المجتمع أنه لازم توكيد الذات، لازم يجي في العيادة عندي يعني تعبان، ما لقى أحد يقدره، ما لقى أحد يأكد حقوقه، ما لقى، فأنت تنفخه تخليه ترفع سقف، you raise the ceiling of expectation، ترفع سقف المطالبات. كلما رفعت سقف المطالبات يتعب هو يتعب أول في البداية، لأنه he will never find anybody who could fit this level of high ceiling of expectation. وجزء منها العلاقه التراحميه اللي ذكرناها اظن في الشابتر رقم 3 اللي هو الاحسان والصدقه يعني مثلا لو تلاحظ مثلا ما في احد هنا شغال تامين ولا شيء ولا محامين الله يستر، ترى فلسفه التامين والمحامين قائمه على العقليه التعاقديه، انه خذ حقك. دائما المحامي اول ما تجي المحامي يقول شوف عطني اي ورقه اي وثيقه اي شيء عشان اصيد الرجال. لكن هذا ما هو بجزء من ثقافتنا اصلا، يعني احنا ما هو بجزء من ثقافتنا انه عطني اي شيء عشان اصيد الرجال. لا، احنا نبي نحل المشكله، احنا نبي نحل المشكله حتى لو تنازلت الاطراف. قبل فتره كنت بالكافي ومحامي، اثنين محامين وواحد شاكي له واحد، سمعت كل السالفه مع انها سريه على بالهم. المحامي يقول له جيب اي شيء، جيب اي اوراق، لو واتساب، احنا نبي نصيده مع كل جهه. انا بغيت انط عليه اقول يا اخي حرام عليك، يا اخي حرام عليك، يعني في النهايه انت ترى يعني تفسد الناس كذا. المحامين صاروا يفسدون الناس. ليس في احد محامي هنا. لا. المحامين احسن ناس احسن ناس المحامين، اجدع رجاله.
السلام عليكم بروف خالد، الله يعطيك الف عافيه. انا دكتور ايمن عفيفي، شكرا على المحاضره الملهمه، واللي ابتدعوني ادعو حضرتك واللجنه والدكتور صالح والمجموعه كلها. ان شاء الله اللجنه يعني تنشر الاسبوع اللي جاي اتمنى. واي نوت اي ثينك، انت عارف حضرتك طبعا يعني كنا نامل في تعريب الطب وتدريس الطب باللغه العربيه، لكن يعني حلم بعيد شويه. انا بتصور اللايف ستايل ميديسن بالذات الستريس مانجمنت والسبيتشواليتي والسوشيال كونكتدنس، هذه الاشياء من ثقافتنا، من لغتنا، من موروثنا، تراثنا الاسلامي، تراثنا العربي. انا بتصور بلغتنا الاحسان، الشفقه، الرحمه، حسن الخلق مش موجود زيها. عندنا مرادفات في اللغه العربيه باي مليونز، هم عندهم باي 100,000. فبتصور يعني لجنه عظيمه وعقول عظيمه زي دي لو نجتمع على بيسموها ديلفي تكنيك، احنا مش فاضيين، فممكن نعملها اوفر ذا نت حتى، وفكره ونراجعها ونعيدها وهكذا لغايه ما نصل للصياغه اللي ترضينا وتبقى من واقع مجتمعنا.
I totally agree. The decision is not on my hand.
أنا كلمت الدكتور خالد بالتليفون. احنا نحاول جزء من طب نمط الحياة في السعودية الدول الإسلامية العربية أن نأسس العلم هذا بما يناسب ديننا وعقيدتنا وبيئتنا هنا. We're not trying to copycat الويسترن لايف ستايل ميديسن per se. ويعني اقتراحي الأول أنا بعيد إن شاء الله نجد تعاون من الزملاء إنه نكتب الجزئيات كلها بما يناسبنا، حتى حنا يعني نجاهد إنه يصير إن شاء الله تعالى نعرف والأشياء الحدود الطبيعية لنا في السكري وغيرها. لكن أيضا وجدت من المرضى بالعيادة يعني فتحنا باب طب نمط الحياة، ندخل في الإيمان، ندخل في الإحسان، وندخل والبر والصلة وتأثيرها على الهرمونات مباشرة وعلى صحة الإنسان. ونعرف بحثيا أنه حتى لما تقرأ مادة معينة أو تشوف فيديو أو صورة أو ردة فعلك حتى للإساءة تأثر عليك جسديا. فإحنا نبغى نخرج من اللقاء اليوم هذا معك دكتور خالد إنه إن شاء الله تعالى نطلع لو بشابتر أو تشابترين إن شاء الله أو 3 اللي تشوفه. أيضا we are in the process of working on developing a schedule for the courses we'll be using to train physicians, pharmacists, nutritionists أساس المسج اللي نعطيها احنا الناس اللي تجينا بالعيادات أو يستشيرونا أو في المؤتمرات تعكس ديننا وثقافتنا هويتنا بالذات. عندنا كنوز في السنة، كنوز في القرآن ما احنا مستفيدين منها. احنا نبغى نطلع في هذه، لو ما نطلع بهذا اليوم الكوميتمنت دي فاحنا ان شاء الله انجزنا شيئا عظيما.
الله يرضى عليك. كل سرور. في الدكتور هنا.
Assalamu alaikum. Thank you very much for an excellent talk. I knew it was coming from your heart. So Jazakallah khair. I think you mentioned very important points about collectiveness, the importance of collectiveness, and not focusing on the individual himself. So I think if we raise the collective, the individual will automatically come up. And I think the advantage of returning to, as you've mentioned in Islamic doctrines and Islamic literature, is that the prescriptions are already there. All the information that we need for all the errors in relationships are already there. For example, in Malaysia, they introduced a system whereby before marriage, there was a compulsory course on how the husband and wife should behave with each other.
Yes, yes.
And as a consequence of that prescription, the divorce rate in Malaysia plummeted dramatically. So I think you're absolutely right. I think especially locally here where the deen is deeply inscribed in people's way of life, Islam is a way of life. I think we should resort to more of that to raise the individual through the collective, inshallah. Exactly.
Thank you, thank you, thank you.
Thank you, Dr. Khalid. Now we'll go for the next speaker. Let's welcome our next speaker, Dr. Muntadhar Bashir. He will discuss the life medicine in hospital workplace practice, what you preach, system transformation. Dr. Muntadhar is currently the chairman and consultant family physician at King Faisal Special Hospital and Research Center in Jeddah. Welcome, Doctor.
Assalamu alaikum. Bismillah, alhamdulillah, wa salatu wassalamu ala Rasulullah. Dr. Saleh, ladies and gentlemen, it gives me great pleasure to be here in Hail today. I was promised by Dr. Nasreen that Hail is beautiful in spring, and it definitely is. And I'm honored to be here. As was mentioned, I'm the chairman of family medicine in King Faisal Specialist Hospital in Jeddah. And it gives me great pleasure to talk about the lifestyle in the hospital workplace, practice what you preach, system transformation. So the agenda of my talk will be, we'll do a little bit of introduction and the background, and we'll talk about healthcare professionals, should we practice what we preach. We'll look at some local data from Saudi Arabia, and we'll talk over again, I'm sure we've heard a few times this week, about the benefits of healthy lifestyle, but we'll talk more specifically about in the hospital workplace, and look at strategies how we can implement healthy lifestyle in the hospital workplace. And a brief mention of the international network of health promoting hospitals, and a little bit of a flavor about little things we've done in King Faisal Hospital in Jeddah to look at employee wellness programs, and then we'll finish up with the challenges and conclusion. So lifestyle-related disease have reached epidemic proportions: obesity, diabetes, hyperlipidemia, ischemic heart disease. It's hugely important to promote physical activity and diet, especially in the workplace. We spend 8, 9, 10 hours of our waking hours in the workplace. So if you're going to implement a change, we're going to get more bang for your buck if we actually do it in an area where we're going to spend more of our time. And the employee health programs can reach many individuals and lead to knock-on benefits, for example, in productivity. And biggest benefits are attained by those who have the poorest health. So those who have obesity or hypertension or chronic diseases are going to benefit more from the employee wellness programs. But unfortunately, research shows that these individuals actually participate in employee wellness programs less, maybe because they're shy, they're embarrassed, or they've given up hope that change will happen. So healthcare workers should have knowledge and they work in the right environment to actually implement a healthy lifestyle. We're a vital group to promote health because we are deemed to be most reliable in terms of our knowledge. So patients will trust what we say because they think we're a healthcare worker, we've had the experience, we've had the knowledge. And healthcare workers' adoption of healthy lifestyle themselves will play a huge role. So if a healthcare worker is conducting a healthy lifestyle themselves, they're more likely to actually ask their patients to do the same. Whereas the opposite is true. If you're not actually having a healthy lifestyle, you're less likely to expect your patients to do the same. And more importantly, patients will more likely listen to healthcare workers who they know are conducting healthy lifestyles. For instance, how many of us would listen to the nutty professor if he told? So we should practice what we preach. We are perceived as demigods by our patients. They have a high we as healthcare professionals have a high standing in society and emulate it. For instance, physicians are able to sign documents and certify identification because of our standing in the community. And generally speaking, healthcare workers preach against unhealthy lifestyles, but themselves, we live unhealthy lifestyles. So we actually are saying, do as I say, but not as I do. And we all know that actions speak louder than words. So an obese physiotherapist is less likely to get his patient to lose weight and do physical activity than if he's not obese himself. And physicians' busy work practices lead to eating a lot of junk food. And despite this, we're asking our patients to do the opposite. And when patients see this, they're less likely to listen to our advice. So everyone knows the risks of cancer with smoking and the risk of alcohol, the risk of unhealthy lifestyle, but we still indulge, and maybe patients still indulge because they see the healthcare workers doing the same thing. So Klein et al. Found that only 10.8% of healthcare workers actually had the recommended intake of fruit and vegetables in their diet. And fewer than half of them performed physical activity 3 times a week. And more than 80% drank alcohol, which was more than the average in the community. And the authors concluded that the lifestyle of healthcare workers fell well short of the standards, and this resulted in them being less likely to educate their patients about healthy lifestyle. And Bakshi et al. Found the same findings amongst nurses. So what about Saudi Arabia? If you look on the right, the obesity in the kingdoms in 2020, a survey done showed a survey of over 6,000 patients, of which nearly 5,000 responded, showed there was a prevalence of obesity in the kingdom of nearly 25%. And that small table, difficult to read, but basically shows that the World Health Organization showed in 2016 that diabetes is 14.7% in males and 13.9% in females, obesity 29% in males and 39% in females. So Mahfouz and colleagues in ABHA found that healthcare workers in government hospitals and primary healthcare centers, 14.8% of them were current smokers and 11.5% were previous smokers. Nearly a quarter had some history of smoking. And Alwan in Riyadh found that there was no difference in healthy lifestyle parameters between healthcare workers and non-healthcare workers. And Atiq and Arawi assessed the 4 main determinants among primary healthcare professionals, and they looked at 322 participants in 4 family medicine centers and found that 8.4% of these individuals smoked. Only 75% of them had more than 50% scores in their healthy diet. 38.8% were actually of normal body mass index. That means 60% were overweight. And the conclusion was that primary healthcare professionals were not up to the expected level of healthy lifestyle parameters, and that healthcare workers needed to be targeted by health promotion programs for their own benefits and for the benefits of their patients. So what's the reason for do as I say and not as I do? I suppose physicians will blame that they were busy in medical school, they didn't have time, too much studying, and they resorted to junk food because it was easy to get and quick to get. That's why they call it fast food, I suppose. And healthcare workers, on the other side, healthcare workers who are obese and then lose weight, it's a great motivation for our patients. So it shows that, to our patients that we do walk the talk and that it is possible to actually lose weight. And healthcare workers are watched, like parents are watched by a child or a priest is watched by the congregation. Our patients will look to us for inspiration. and get negative feedback as well. If we're not doing the right thing, they're less likely to do the right thing. So if we really want to implement, healthy lifestyle in the hospital workplace, we have to try to make sure that we are leaders in this for our patients. So a leader leads by example, whether he intends to or not. So in terms of healthy lifestyle in hospital workplace, chronic disease, as we know, is the top reason for death and disability and consumes 86% of the healthcare budget in the US. And 50% of adults have at least one chronic disease. And WHO found that 80% of heart disease, stroke, type 2 diabetes, 40% of cancer is preventable by lifestyle changes. And $3.35 trillion are spent every year on healthcare, which is basically around 20% of the GDP. And this will increase. The right side of this slide, you can see the actual map that we've all probably seen many times before of the increasing rates of obesity in the United States. In Australia, they found that healthy employees have 3 times more productivity and complete 143 effective hours of work, whereas unhealthy employees complete only 49. And unhealthy employees take 18 days of sick leave a year compared to 2 days for healthy. And if a person feels 20% less well, they will decrease their performance by 10%. And 20% of improvement in morale results in less absenteeism, less presenteeism, and less turnover. And again, return on investment, many companies outside healthcare sector have also found the benefits of lifestyle changes and employee wellness programs in return on investment. Johnson & Johnson proved that they improved by $1.88 to $3.92 for each dollar spent on health, on employee wellness programs. And Baker et al. Found that medical costs for their employees decreased by about 3.27 for every dollar spent, and absenteeism declined by $2.73. And the Dell company also found similar returns of investment. So we know that it works, we know that it's financially beneficial, but we just need to find a way of implementing it. Now, just briefly talking about polypharmacy, as defined by the fact that they take 5 medications or more, it's made worse when people have multiple medical conditions and they are seeing multiple specialists. Maybe they've got mental health problems already and they reside in a long-term care facility, and they have poorly updated medical records, or they have automated refill services, or the physicians are trying to reach targets in terms of parameters and metrics that actually increases the risk of polypharmacy. But adherence to medications is an epidemic problem according to the World Health Organization. So non-adherence in chronic diseases averages about 50% in 1 year. So 50% of the times, by 12 months, our patients are not taking the medication that we give them. In Europe, non-adherence costs 125 billion euros and contributes to 200,000 deaths every year. And 3 in 10 patients stop taking their medications before their first supply runs out, right early in the actual management plan. And 24% of patients take less than the recommended dose, and 31% of patients do not refill the prescriptions or do not fill the prescriptions that they are given. So a question, do doctors like video games? What's the answer? We all know about the PS5, PlayStation 5, 5th version. He likes it, yeah? There's a new kid on the block, the PCSK9 inhibitors. So has everybody heard about these? It's a new toy, much more expensive than the PS5. So one course for 1 month for a PCSK9 inhibitor to bring down cholesterol costs $450 now. It used to be a lot more than this, but a lot of negotiating with drug companies, they brought it down to $450 per month, 1,600 reals per patient. And in 1 year, maybe 50% of the patients won't be taking this medication. So I was in a conference in Dubai last week, and we had some excellent talks on lipid management, and the specialists were very well renowned, and they're talking about, let's get the LDL down as much as we can. They were talking about the new guidelines. If you're very high risk of ischemic heart disease, get the LDL down to 45 milligrams per deciliter. And they're saying there's nowhere, there's no such thing as too low. You can get the LDL down to 0. There's no evidence that it causes any harm. And if we are finding that we're not achieving the targets with statins and ezetimibe, add the PlayStation 5 to the equation, and get the cholesterol down as quick, or the LDL down as quickly as possible. And unfortunately, he also said clearly and frankly, don't waste time on lifestyle. It doesn't work. Let's get this LDL down as quickly as possible. I'm sure people in this room will disagree with that defeatist approach. If we're not succeeding in convincing our patients to have a healthy lifestyle, then we're doing something wrong. We should change our tactics. And like Dr. Nasreen said earlier, maybe we should think about coaching. Maybe we should think what Dr. Khalid said about looking at the collective wellness of our patients. Bring up the collective, and then the individual also always rise automatically as well. So the paradox is that we know that non-adherence and polypharmacy is a problem, and unfortunately, the short consultation time, we can sometimes just basically push medications or procedures, but patients can be hard to convince and do the opposite of what they are told. And this stems from the very first dietary intervention given to man. Allah said to Adam, don't eat from this tree. That's a dietary intervention. What did he do? He ate from the tree. And this was Allah speaking. So how are we going to be able to convince our patients when the Almighty couldn't convince the Prophet? So again, we just do need to focus on trying different techniques and trying the collective. And I like the picture on the left where the doctor is explaining to the patient with the severe coronary artery disease. We've got two options. We can do a cabbage on you coronary artery bypass graft. It's going to cost you $100,000. You're going to be out of action for 2 months recovering. Or we can switch you to a plant-based diet. And the patient says, plant-based diet, doctor? That sounds really extreme. So exercise. I wish it was as easy as this. If we saw patients and we can give them a prescription exercise, alhamdulillah, they go away and they start exercising. We give them a prescription for diet, they go away and start dieting. We give them a prescription for losing weight, they go away and they start. Unfortunately, it's not as easy as that. And patients, unfortunately, want to have easy options. People like to try the back door. The people like to try, no pun intended, but there's no such thing as a free lunch. We are expecting our weight to go down by some magic wand. And unfortunately, there's an epidemic now of the GLP and the SGLT2 inhibitors who basically patients are taking just to lose weight because they don't want to try the diet and exercise. And I'm sure colleagues in the audience will find, patients will come to us and say, doctor, I'm taking too many medications. I must stop some of these. There's too much. Can you help me? Tell me which ones I can stop. So you say, okay, right. Your diabetes medication, you need to keep taking that. Hypertension, I'm sorry, you'll need to keep taking that. The lipid medication, sorry, you'll need to keep taking that. Okay, you can stop your Centrum. Patient says, multivitamins, no, doctor, I want to keep taking this one. The only medication that has no proven benefit, the patient wants to take it. They think there's some magic inside it, but doing a lifestyle change, keep taking the chronic disease medication, they don't want to do that. So what is the SAD diet, standard American diet? We know pre-packed foods, processed meat, high sugary drinks, high fat dairy products, eggs. And unfortunately, this makes us physically sad and probably mentally sad as well. But don't worry, our hospitals are not like that, are they? We encourage more healthy eating in our hospitals. Unfortunately, we serve fried foods in our hospitals. We have outlets of fast food chains in our hospitals. And we have vending machines which serve very unhealthy food. So we should, in hospitals, try to encourage people to do things that will go outside in the community and carry on that good behavior. But why don't we do that? We're worried about patient ratings. We're worried about Press Ganey scores, patient experience. They'll give us a bad score. So if we make them unhappy by giving them some food that maybe they don't enjoy when they're in the hospital, they'll give us a bad score. And then maybe we'll have a bad rating in the community. And there's no standards to follow. What is healthy food? Even JCIA doesn't, JCI in their standards says, encourage healthy food in the hospital menu for inpatients. It doesn't say what that comprises of. So there's no standards. And maybe physicians or management don't know what's being served in the hospital. So that's why they probably don't intervene and maybe try to encourage anywhere within the hospital premises to have healthy options. And there's a little short-term financial gain. Sometimes, you'll have a fast food chain paying rent to have space within the hospital premises. And this will basically encourage the hospital management. Okay, we're making a little bit of money. Unfortunately, it's a short-term gain, but a long-term loss. Some interesting findings by one of the researchers about cardiologists and their knowledge of diet or the types of diet that they should be kind of educating their patients about. 90% of cardiologists report receiving no or minimal education about nutrition during their fellowship training. 59% no nutrition education during internal medicine training, and 31% reported receiving no nutritional education in medical school. And 8% believe that they were experts in nutritional knowledge, but 95% of them agree that they should be experts if they are really going to be able to pass on the right information to their patients. So really, we should be focusing on healthcare instead of sick care and make it more holistic. Unfortunately, this specialist in Dubai last week, the topic of his talk was the holistic care approach to but he wasn't talking about lifestyle. He was talking about holistic in terms of drugs for hypertension, drug for lipids, drug for the diabetes, drug for the weight loss. And I unfortunately couldn't kind of sit down. I had to stand up and ask a question, and I queried him. I said, I'm sorry, you have to change the title of your presentation. It's not really holistic care. You're talking specifically about medications. So we have to think about healthcare. Unfortunately, there's a parable that we have in the UK that when there's water on the floor in the kitchen, you can keep wiping the water with the mop. Let's get rid of the water. More water is coming. Let's keep wiping the floor with the mop. But the sink is overflowing, and more water is coming. Dr. Raj is saying the answer. So the sink is overflowing because the tap is on. So why don't we turn off the tap? Then we don't have to start mopping the floor. So the root cause of our patients' health problems is poor lifestyle, poor choices, no activity, no diet, no exercise. But then we're treating that with medications. We're not treating the root cause. So this is a book by Simon Sinek, Start With Why. And in the book, he mentions a golden triangle. And he says the best companies in the world look at why they're in the business first, and that's the center of the circle. And then they move on to how and what. And he mentions and cites Steve Jobs and Apple, that when Apple became so big because Steve Jobs wanted to know why he was in the electronics business, why he was in the mobile phones business. And that led him and his team to develop the best technology. They didn't say, okay, how do we make the best phone? What do we make is going to be the best, is going to be basically separating us from our competitors? They said, why are we in this business? And then they said, okay, we're in this business for X, Y, and Z. And then they moved on to find out how to get there. Same thing we should do in healthcare. Why are we in healthcare? To make people better, to keep people healthy, not to treat people once they've already got the disease. So we have to re-engineer our mission, our vision, and values in our hospital. And this has to be done to enable the organization to change its culture. So all the employees in the hospital have to have the same understanding about healthy lifestyle, healthy behavior, healthy choices. And as we all know, culture is one of the most difficult things to change within an organization. So the wording of the mission and the vision will allow all employees to focus on healthy lifestyle. And the reason for existing, the why, as Simon Sinek says, will be we want to make our patients more healthy, and then they will be able to focus on how to get there later on. So just as an example, a vision statement for a lifestyle clinic in North America, our vision is for every individual in our community to experience optimal holistic health based on principles of lifestyle medicine. Or the mission, our mission is to help our community and patients experience holistic health by preventing, treating, and reversing disease using evidence-based lifestyle medicine. Now, majority of the body of those mission and vision statements can be kept. And we work in secondary care hospitals, we work in tertiary care hospitals. Of course, we don't want to say we're lifestyle clinics. Maybe we can remove the last three words, but the basic concept of the body of the mission and the vision can be captured by the majority of what's written there, encouraging our patients, encouraging our employees to actually adopt a healthy lifestyle. So if we really want to adopt and implement a healthy lifestyle in the hospital workplace, we have to start marketing our plans. We have to start developing a strategy. And our message has to be very, very, very carefully constructed. A message, one hat doesn't fit all. One message won't fit everybody. So when we're trying to reach out to admin, we have to tailor the message to let them know that it's better on the ROI, it's better on the bottom line, It's better for the cost-benefit analysis. And physicians will need to be convinced in a different way. Physicians are very data-driven, science-orientated, so they'll need to see evidence-based arguments that are backed up by research that show that lifestyle medicine does work. And remember, medical administration is mostly from the medical background, so you'll be able to convince them in the same fashion with data. Now, we interrupt this presentation with a news flash. There's a breaking news. I'm not sure how many colleagues in the audience know anything about cricket, but while I was preparing for this presentation, I quickly flipped on. As you know, sometimes when you're lazy, you go see what's going on in the news. And I saw that Shane Warne, a famous cricketer from Australia, died a couple of weeks ago while I was doing the presentation. And it was a news flash. And he's 52 years old, a sportsman, one of the best cricketers in history over the last 150 years. Some people say he's the best cricketer ever. He was 50. He had problems with weight. He had problems maybe with healthy lifestyle. And he was found dead in his villa in Koh Samui in Thailand. And I thought, wow, that's a big coincidence. I'm preparing a talk on lifestyle medicine, and this is happening. And this just shows how important and how urgent it is for us to actually move with this movement and forward and try to encourage all our hospitals to adopt this so that we can encourage the community to do the same. So again, the WHO says ischemic heart disease is the biggest killer across the world. And it's getting worse. The actual rate of increase of death due to ischemic heart disease has increased from 2000 to 2019. So to find evidence, Dr. Dean Ornish did a study in 1990, which is quite a while ago, but he looked at 48 patients, and 28 patients he put in the intervention group, which meant having a healthy lifestyle, low-fat vegetarian diet, stopping smoking, stress management, and moderate exercise. And 20 of the patients carried on the usual cardiology management. And he found after 1 year that stenosis regressed from 40 to 37% in the experimental group, and from 42, and it increased from 42 to 46 in the control group. And where the lesions were more than 50% stenosis, the regression was 61 to 55 in the experimental, and an increase from 61 to 64 in the control group. And they found that comprehensive lifestyle change bring about regression of severe coronary atherosclerosis after only 1 year without use of lipid-lowering drugs. Now, this specialist in Dubai last week said, well, there's only one study that there was in one study they said LDL will go down in 7 to 8% by diet and exercise, by lifestyle changes. But I said to him, you're only looking at one parameter. So the whole composite effect of diet and exercise and weight loss is going to be affecting the blood pressure, affecting their diabetes, affecting their lipids, so don't just look at the number of the LDL. LDL went down, but did this change? And we can see from research and from science that it actually changes the anatomy within patients who have coronary artery disease. So a more recent study done in 2014, basically 198 consecutive patients on a plant-based diet. So those who opted to be in the study were 177 of those 198, and they found that the rate of events was decreased in the intervention group, and the ones that didn't participate in the study, which was basically 13 of 21, had an increase of adverse events. And on the right side, you'll see that in the angiogram, after 32 months of a plant-based diet and no use of statins, the anatomy of the left anterior descending is returned to normal. The stenosis is resolved. And on the left side, the nuclear imaging scan shows only after 3 weeks of a plant-based diet, you got increased perfusion in the myocardium. So what experience did we have at King Faisal in Jeddah? We conducted a war on weight program within our hospital. So we invited staff, we did a questionnaire, we had 100 respondents, we shortlisted those with the high BMI, we screened 48 and came down to 30. We built up 5 teams, 2 from nursing, 1 from MCA, 1 from clinical services, 1 from admin, and we put them through an 8-week program of exercise, diet, and medical support. And after 8 weeks, we found that the total weight of the 30 employees was initially nearly 3,000 kilos, and it came down to 2,700. So they lost 181 kilos as a group. So that's like 3 full-time equivalents. If you could say 60 kilos, 60 kilos, 60 kilos. And I went to a talk recently where if you remember, I was a medical student, we used to learn that the average male is 72 kilos and the average female is 60 kilos. I think those average are extinct. They don't exist anymore. I think the new average is much different to this. But if you look at this individual who won the prize for the most weight loss, who lost nearly 17, 18 kilos in the 8 weeks, he went from picture 1, picture 2 to picture 3. And we heard lots of stories from employees. We invited them to the actual presentations, and they were giving some wonderful heart-wrenching stories that it not only affected me, it affected my family, affected my kids. My kids lost weight, my dog lost weight, whatever it was basically having an impact on the community. And it made them feel stronger because they're working together as a team as well. So involve yourself in research and gain credibility for your movement. So we intend to publish the data from our WOW program. We already submitted the IRB proposal, and we've also done a health risk and needs assessment survey, and we will act on these findings. So again, develop the movement, involve your academic and training department in your hospital. Conference like this, do workshops, educate the healthcare workers about the importance of lifestyle medicine, and do outreach into the community. So involve your community relations department and go out to schools, go out to malls and convince the people at large that this is a good thing to do. And as Dr. Khalid said, the collective is important. If everybody's doing it, people will be pulled through, whether it's by the fact that they are there because of their own reason or just because of peer pressure, or because they're seeing other people do it, they will do it as well. And use the power of social media to send your message across and get more and more people informed about the right things to do. And do we do the big bang, or do we do the phased approach like we do in IT technology? Do we go live slowly, or do we go live quickly? There are advantages and disadvantages to each method, but really menus across the hospital have to change in inpatients, in staff cafeterias, in doctors' lounges, in patient cafes. And we must start spreading the word and walking the talk. So what challenges could we face? We're worried about the patient feedback, the Press Ganey scores, patient experience scores. We're worried about the expense. Is this going to be more expensive? And they found in the US that it's actually, these type of plant-based menus are not more expensive than the regular fast food junk menus. And people will get bored of them. And they found that if you actually have good recipes, people actually eventually do start enjoying them as well. And they say people don't like this type of food, it'll be too complicated to have different food choices. But we do need to have solutions like education on discharge, nurses to help with the patient and family education, pre-discharge instructions, and showing promotional videos on the benefits of plant-based menus. What are the challenges will we face? I mean, leadership buy-in, we really need to have leadership behavior is the single most effective and cost-efficient way to infuse new behaviors in the organization. So we really need leadership support. We might, when you start talking about vegetarianism and plant-based menus, we might start being labeled as the bizarre physician, and we might be ridiculed by our colleagues. But gradual acceptance will occur, and we need to win the hearts and minds of our community, and we need to start advocating and aligning to the new way. So when we're dressed in Spider-Man gear and our friends have got Batman gear on, we ought to be able to cope with being the odd one out, inshallah, until we can basically meet together. But what is the long-term sustainability? We don't want to have a flash in the pan, fad diet like they do with the Atkins diet. People are on it for 2 weeks, 4 weeks, 6 weeks, and they can't sustain it. Same thing for the lifestyle modification or lifestyle medicine in the hospital workplace. It needs to be sustained. So you don't have a WOW program 1 year, next year we have nothing and nothing goes on. There has to be continuous effort and continuous way of sustaining it. And I would suggest that we use the Hawthorne effect to our advantage. And we all know from quality management, the Hawthorne effect is when something is being studied, people are being studied, they are more likely to change because they know they're being observed, so they think, oh, I better change my behavior. So they found in psychology and in quality management that they call it the Hawthorne effect. If you're studying a group of people without doing any intervention at all, just the fact that they know they're being studied, they're likely to change. And this we know happens when so many of our hospitals have got accreditations now with JCIA, Sabahi, and many others. We know that these accreditations, the surveyors are coming, and we know how hospital staff get together quickly and start revising the IPPs. And 3 weeks before Sabahi comes, we're all running around trying to get everything together. But it's a learning exercise. The Hawthorne effect is happening because it is bringing about change. So it'll really, applying for accreditations will really keep us motivated and focused. There'll also be great marketing tools because when patients know that we're accredited with different bodies, they're more likely to come to our hospitals. And as the kingdom is transforming to basically a privatization, or shall we say not for profit, I think this is going to be more important in the insurance market, when patients are able to choose the hospital that they go to, they're more likely to choose hospitals they feel have got better ratings. And it will help in recruitment and retention. Like we know with magnet programs, nurses like to work in a hospital that's accredited with magnet. And as I learned from my MBA, it's easier to keep one customer than it is to gain another customer. And if you have a positive experience, you're likely to tell 10 other people. But also, if you have a negative experience, you're likely to tell 10 more people. So we don't want patients to leave us with a negative experience and decrease the chance of other people coming to us. So a great place to work certification works in other industries, and there's no reason why it shouldn't work in the healthcare sector. And the International Network of Health Promoting Hospitals and Health Services started off as an initiative by the World Health Organization back in the 90s, but in the mid 20s it came as a charity organization, and they basically have standards hospitals to be health promoting. And this way we'll be able to actually benchmark ourselves with other organizations. So, and if we get accredited with Great Place to Work, we will know they're coming next week for survey. We will push and we'll keep moving, and that sustainability will be kept, inshallah. So in conclusion, to enable that system transformation, we need to realize the benefit of lifestyle medicine in the hospital workplace and engage and educate our patients and patient organizations, health professionals, hospital owners and management. And we need to have sustainability by striving for accreditations. And lastly, I'll tie up my talk with Dr. Khalid's talk. A lot of the research I did from local and from from Europe and North America, all the publications really talked about the 4 or 5 parameters of healthy lifestyle, from diet, exercise, sleep, weight loss, smoking, alcohol. None of them really mentioned the spiritual aspect. And basically, if we look at what's written in the Quran, I'm sure there's a lot more ayahs better than this, or as good as this. Eat and drink, but not to excess. And one hadith that we're all familiar with, fill your stomach, but 1/3 should be food, 1/3 should be drink, 1/3 should be air. Now, if we place these notices in the kitchens or in the cafeterias, just as a blip word for our patients, employees, and their relatives and friends, etc., maybe that will just make some people back off. They went to get that dessert and they said, Malish, I think I'll keep my 1/3 empty. So as my last comment will be the pun, is that we need to think about, if we want to implement hospital lifestyle medicine, hospital workplace, we need to think about the food for the soul as well as the food for the body. Thank you very much.
Thank you, Dr. Muntazir, for the nice talk. Any question?
Thanks a lot, Dr. Muntazir. Excellent presentation, integrating the hospital-based and the community-based lifestyle practice. I do agree with you. It's not a question, just highlighting. It's very important for us to remember always our colleague inside the hospitals. We have not only in lifestyle medicine to target primary health care physician and the preventive and public health physician, but we have to target our colleague. So when we found a colleague like your colleague, when he mentioned that don't waste your time with lifestyle, this is what we want really actually to invest in. PCSK9 is an excellent weapon that we for sure we will use whenever we need it, but we have not at all to forget the weapon of therapeutic lifestyle approach. So I do think no one here in this hall are calling that lifestyle practice can replace or will replace totally the use of medication. But what we all call for is to integrate all the weapons that we have. And the lifestyle practice is the foundation and should be the foundation. And sometimes it may be with intensive protocol, may exceed even whatever the medication which we can use. Thanks a lot, Dr. Muntazir.
Thank you, Dr. Muntazir, for raising very important issue regarding the workplace wellness in the hospitals. In the Eastern Health Cluster, we have a good experience now. I can talk about several teams in Dhahran Eye Specialist Hospital in King Fahd Specialist Hospital who are they are working with that now. We conducted our need assessment on more than 3,500 employees. And the interventions are being built right now by our teams. And also other hospitals, maybe our experience more advanced in the PHC level, because things are easier to be conducted in the PHC environment, but in hospitals it's real difficult because people are real busy, especially in the ICU, emergency department, and the operation department. So I think it will be a great opportunity to exchange our experience with your team, especially that we have that WOW program. So I hope that we build collaboration in the upcoming days, inshallah.
Thank you very much for the comments and the feedback, and really it would be a great honor for us to join you. I think this is what we need to do, is that we need to get this community together. We need to actually get the movement started, and this will help us to actually get that information across all walks of life.
That was my comment. He got it. So I think we need to get together to work on having healthy healthcare systems to begin with. And I agree with you. In the United States, about 30 years ago, cigarettes used to be, sold on each floor. So when the physicians are rounding, they're smoking at the same time. Not anymore. But we have to be careful with drug companies and other companies who are promoting their products. I don't blame them, but I think we are in competition. And also there is presenters and lecturers who, they have a second agenda sometimes. It's not announced, i.e. they are promoting medications. And you have to look behind or between the lines to find out what's going on. I thank you for the great lecture. And following Dr. Khalid Jabir, this is a good compliment lecture. And I think with regard to lifestyle medicine practices within hospitals, there are some leads here and there, but we need to build a lot more on this. And hopefully with King Faisal Special Hospital and Research Center in Jeddah, we are planning to have a provincial conference every month. So maybe we'll talk to you and have it with King Faisal, inshallah ta'ala, in Jeddah in the next few months. There will be 12 per year, and there will be a crown conference in Ha'il every year, inshallah ta'ala. The other thing is we could work together and establishing, the standards of lifestyle medicine, like I said with Dr. Khalid when I commented during your lecture, is we don't have to follow, the Western style of applying science and medicine. And I think we have great material. We just need to bring it out. And I was looking for collaboration to bring lifestyle medicine in the Prophet's life and also in the Quran and Sunnah, and formalize it in a modern way to use it with our patients and clients. And it's one way to get the jewels of our faith to the rest of the world.
Fantastic, excellent comments, really appreciate that. Deserves a round of applause.
Thank you, Dr. Muntazir. I'm so glad that we have you today. It's our honor. And I always remember that you was my consultant when I was rotating as intern in King Faisal Specialist Hospital. And from day one, you are advocate for lifestyle since that time. It's wonderful talk, and you like connecting dots together for health workers and hospital organization, and even on the level of patient. And I agree with you. It's when you are targeting and focused on healthcare worker lifestyle, you're like throwing two birds one stone. So you can, if you targeting a physician, all his patients will gonna follow. So it's really great investment from King Faisal Specialist Hospital to do this, like this program with the focused on healthcare worker. And it's a great idea if we can spread this experience for all hospitals, at least at Jeddah, as a starting point in King Abdulaziz University Hospital, in MOH. So we can do it as a pandemic or something in Jeddah, at least. Thank you so much.
Thank you. Just one final comment. I think what Dr. Afifi is talking about, I think we and myself are not advocating that we give up any type of old medicines. I mean, they have their role, they have their place, and they will have, for instance, PCSK9 for people with severe familial lipidemia. They've got high risk of coronary artery disease and death at a very young age. Those subgroups, cohort of patients will be basically treated with these type of medications, and we respect our work of our specialty colleagues, etc. But when we, as Dr. Raj is saying, when we're looking at being slaves to the pharmaceutical industry, that's when it becomes of a concern, when the agendas are there that are not really realistic, and we're basically spending a lot more money. If you look at spiraling costs of healthcare, the non-adherence to medication, patients don't take the medication 50% of the time. Yes, we're spending more and more on drugs, and those studies will show within that time frame of that research that gave benefit in decreasing the LDL. What's the long-term impact? The patient didn't take the medication after 1 year. So in your study, you said after 8 weeks, we stopped the trial, the LDL came down, and in that very controlled environment, the patients were doing really well. When they're not seen by their family physician or support in terms of lifestyle medicine, they will go back to the bad habits and they'll stop taking the medications. So definitely we weren't proposing that we stop medications for all patients, but make sure that we do it specifically for those that need it, and those that don't, let's push as much as we can to get lifestyle changes.
Yes, I think we shouldn't allow to create a tension between drug approach and lifestyle approach. And I will just borrow a similar case example in between psychotherapy and psychiatry. We don't want to create a tension and the competition between psychiatry and psychotherapy, because both of them are approaches, both of them are good, both of them, but some of them are fit for some people and some of them fit for others. But usually the people who are advocating for drug approach, the only drug approach, let's call it the drug only approach, okay? Those who are advocating for drug only approach, they claim that patients adhere to drugs more than lifestyle. But in fact, this is not true. I mean, at least 50% of patients who are giving drug, even in psychiatry and in general medicine, they are not taking medications either because of side effects or because of chronicity of the illness itself. So we are almost in the similar compliance rate and adherence rate. This is very important. Thank you.
This is just a follow-up, continuation. When I ask patients in my clinic, do you prefer lifestyle modification, one after I explain lifestyle interventions, or drugs, medications? The majority would go for lifestyle modification, but sometimes I interfere and I say we need to add some medication sometimes. It's not just lifestyle. Some patients do need medication. We're not, Dr. Khalid says, in competition with anybody. And also I want to point to a very important topic that people can forget. One, don't get emotional about it. You know, emotionality is good, give you passion, you want to go and do it. But at the same time, like Dr. Khalid said, it's not every patient will be amenable for either all drug, like all or none, you know, all drug or all lifestyle. It's a combination. And I have a 72 plus man, young man, I call him young man, everybody. And he was so happy that I took 2 of his diabetes medication. He takes 6, so I reduced it to 4 after improvement. And also, akramkumullah, his constipation improved. He said, this is the first time in 10 years I could go without taking, you know, constipation medication. He was crying, actually. So he was so happy, he wanted to stop everything. I said, no, don't stop everything. We're gonna grow gradual. If you need to stop, I'll let you know. If you don't, I'll let you know. But we have to take the combination, because some people do have physiologic, organic changes in their body that requires medication, and some don't. I think we have a great chance with like diabetes, early obesity, early hypertension, early hyperlipidemia. And people in general, they prefer non-drug approach. And I think Dr. Mohammed Mansour, I was thinking of you just now. I think we will do a study, maybe a 3-center study. King Faisal, King Saud University, Cluster 2, King Fahd Medical City. Let's see the attitude of people. What would they prefer after we explain to them the two approaches? You know, so the question would be three. You want lifestyle, you want medication and lifestyle, or just medication alone, and see what they say. This will be a big, you know, I think will influence even decision makers, you know, on supporting lifestyle interventions, because it doesn't cost much. The patient pays for everything. We just, you know, counsel them, give them the PAB, you know, train them how to do it, and they do the rest. And also, in the model of care, activating people. I did not like the word activating. I think we need to get people to be part owners. We're not activating them. We're just giving them their natural role of taking care of themselves. The old healthcare system took it away from them. Just give them a pill, let's do surgery, and you have to do it. There is no discussion usually in the past. But I think giving people choices, and I usually tell patients, what do you like? You have to choose. You choose. You have to discuss it with them. Sometimes I do make choices. You know, for example, I have 3 patients that I chose for them to have open heart surgery because they called me after the cath lab and they told the surgeon, I will not decide, my primary care physician will decide for me because he could not make it emotionally, it was difficult for them. And it was the best approach because they have closed vessels. There is no other choice at that time. So I don't know what you think, Dr. Khalid. And
Exactly. I think very, very, very wise comments. I think at the end of the day, I think the natural fitra is within us of having peace and security, but we want to, unfortunately, we're in competition with other people. So we want to know what, we want to be better like somebody else. We want to do, we're imposing things on ourselves that are basically brought out by society, not what we want. So if you leave it to ourselves, maybe we'll be happier, we'll become more content. It's like the analogy of the man who climbs a mountain, he gets to the top of the mountain and he looks and he's not happy. He wanted to climb the mountain. Then he says, there's another mountain over there. I want to climb that mountain. So when we're competing, we will never finish. When we go back to what's good for us, this is when we will finish, inshallah. And again, as Dr. Khalid says as well, and yourself, Dr. Raji, is the collective benefit, I think, at the end of the day. I think we will be able to move up. And again, we don't have to necessarily within our culture adopt things that don't fit into our culture from the West. We can use whatever is beneficial and add to it to enrich it more. And I think that's probably where we're going to win, because I think, like I said, Islam is a way of life, and we have, so much prescribed ways of behaving in different aspects of our relationships with people, or our behavior, or our conduct, or our exercise, or our diet, that we can get those prescriptions. And if we can get those into a program, a standard format, we can start using that and using that as our template. And this is what we can start maybe using as, instead of the health promoting hospital standards, we can adopt our own standards. And this is where we can succeed, inshallah.
Thank you, Dr. Muntadhar. Now the 4th session will start. Dr. Wahab.
Welcome again. We will start the 4th session of the day with a special topic, which is sleep physiology and sleep disorder with Dr. Wadha Al-Ataibi. She is working now as assistant clinical professor at King Saud University, pediatric consultant, consultant of sleep medicine, and co-chairman of Sleep Lab, head of pediatric pulmonologist section at King Fahd Medical City in Riyadh. Welcome, Dr. Wadha Al-Ataibi.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope with my lecture nobody will sleep. And me, I felt sleep really. So the topic about the sleep, all the lecture at the beginning of the conference, they talk about the diet, about the psychology, disturbance, everything. We have to know everything. We can fix it if we fix our sleep. And I remember when I did my fellowship in pediatric sleep medicine, and I tried to open my clinic, they asked me, what's clinic for pediatric sleep? They don't have. If our kids is sleeping, this is well and good. And they didn't understand there is so many sleep disturbance would cause social problem and economic problem. And that's why, if you notice, Now they are opening a special class in the school, and many mother and father receive a call from the school, your child have attention deficit, hyperactivity, and he is labeled as a special need, and they open for them a special class. If we go and review their sleep hygiene, we found that the main reason for that is their sleep. So I will highlight about what is the definition of the sleep, physiology of sleep, what is the structure of our sleep, and the importance of sleep. And then I will highlight some sleep disorder, healthy sleep. Then at the end, I will give you the warning sign of unhealthy sleep. At that time, you need to seek a medical advice from sleep physician, and I will give you some home message. So what is sleep and how would you describe it? It's very important. There is many criteria for that. It is a state of unawareness and it is reversible. That's why we have to differentiate between sleep and death. It is reversible. You will feel you are away from the surrounded. You will have low physical activity level. You have reduced in your sensory awareness and reduced response to the external stimuli. But that reduce in your external stimuli depends on which stage of the sleep you reach. Of the sleep, Alison Harvey, he described that it has a critical role in a wide range of cognitive function. Like if the one have problem solving, like in the math or in the judgment in his work, if he didn't have a good sleep hygiene or he didn't sleep well, he will not able to solve it. So the importance of sleep helping you in problem solving, in your attention, also in the memory and the creativity. And sleep also important for our muscle formation and repair and motivation and your mood. It is also essential for preventing and recovering from many health problems. So everybody hear about sleep hygiene. We don't mean by sleep hygiene, it is sterilization. No, we have to know the meaning of this terminology. It is a term usually used to describe a set of behavioral and environmental that may influence in our sleep quality. So I will give you like this circadian rhythm, and it is a sleep and awake cycle. It is a 24-hour cycle. And that's part of our body internal clock running in the background to carry out our essential functioning and the process. And in this time of the midnight and in the noon, you will see what is the best coordinating system happening and what is the peak of your physical activity. And all of that is related to our physiology of the sleep. I will describe like this. Is it when we start to feel asleep, or if I want to adjust my sleep, do you know there is a special for that? Important to have enough sleep at night. You cannot say I will sleep now and they have very high lights. No, you need a dim light or off light. The reason for that, because it will send a message to your brain. So what it will happen? The light, it will make an inhibition and stimulation to send the message to your brain, and it will go to the suprachiasmatic nerve, go to the suprachiasmatic nucleus, and there is one hormone there is called melatonin. It is responsible to initiate our sleep. So if you are exposed to the light, you will not able to release that hormone, which is initiate your normal physiology sleep. We are talking about normal sleep. Of course, anybody can take some medication and he will go for sleep, but we need normal sleep. I can summarize this in this slide. Like when you have a light, when you have a light, it will send the message to your retinohypothalamic tract by the rods and the cones. So it will send the message to the suprachiasmatic nucleus and ask him to release the melatonin, which is normal hormone. Now, if you find in the pharmacy, you will find over the counter, no need prescription, some melatonin. We will take it if we have a jet lag or you travel outside and there is a differentiation in the time, you can take this melatonin just only for a matter of 1 week or 3 days to adjust your sleep pattern. So this is the sleep structure. Is it everybody will go to the sleep? We are going in the same? No. We have to differentiate. If you are sleep deprived, like the physician or the security or the one who have night shift, they will go in different stage of the sleep. So we can divide it into REM and non-REM. What we mean by REM? REM is rapid eye movement. And this is we call responsible for you will lose the control of all your muscle, involuntary muscle. But non-REM, it is a light sleep. Okay, so they divide it into another criteria. What is REM and non-REM? I can show you on this slide. This is the important. REM is very important in neonatal period. Why? Because it is responsible for the mental development. And non-REM, it is responsible for physical growth. Okay, so once we grow up and in adult, we will find we need the non-REM because your mental development is already finished. So you need only the growth hormone, your statures, your muscular belt, your nerve, your bone. This is very important. So this is simple slide to make it as live. So we have to know REM and non-REM. This is related to the sleep physician, and we'll do that through our scoring when we do for the polysomnography at night. We will know how many REM you go in your sleep or how many non-REM you will go to the sleep. The one who is go over the night and he didn't pass through a REM stage, he have a problem. The one who have exceed the limitation of non-REM also have a problem. So I try to make a summary of that. You have to know this is an adult. In REM stage, you have 25% of your total sleep. It should not be more than this one, indicate other disease. If it is less than, or you have insomnia or difficult to initiate sleep. In non-REM, you have a total 75 to 80% of your total sleep, and it is responsible for our physical growth. The other thing in your brain activity is very active in REM stage. That's why we are saying it's for mental developmental, but it will be less active in non-REM stage. Muscle activity, it will be completely paralyzed in the REM stage. That's why if we have any patient who have problem in snoring at night, or he have some neurological problem, or he have some insomnia or taking medication, we can pick up the abnormality from respiratory and muscular and neurological once he go to the REM stage. And the changing with the age, we have to know REM will not change with the age. Even when you grow up, when you reach to the more than 60 years, you need 20% of your sleep is REM. The other thing, your body temperature, you have unable to regulate your body temperature during the REM, but you are able to regulate. What do you mean by that? During your sleep, when you feel you are shivering, if you are in REM, you cannot to cover yourself, you have a shivering. But in non-REM, you will wake up and try to get a blanket to cover yourself because easy to be awake. The eye movement, it will be present in REM. I hope this is clear. So why do we sleep? It is estimated that we spend a third of our time in the sleep. So this question is directed to the one, William Dement. He is the founder of the Stanford University Sleep Research Center. And many ask him, after 50 years of your research, do you know why you are the people spending 1/3 of their life asleep? You know what he was answering? He answered that, as far as I know, we need to sleep because we get to sleep. Then the research after him is going to describe all of these after they pick up the neurological. So we found the sleep, it will affect in our neurocognitive function. Neural developmental is very important. So we notice as a pediatrician, if we have the neonate, he doesn't sleep very well, secondary to prematurity, or he is in milk formula, or he have other abnormal GI problem, his IQ, it will not be compared to the other is normal. He will have attention deficit. He will have hyperactivity. Learning process, they will have the children who is not taking enough sleep, usually they have a problem in their calculation or in their math and in their even judgment. Emotional regulation, emotional we have to know. Children, if they are sleep deprived or they didn't get enough sleep, second day they will be hyperactive. They will be very anxious. In compared to the adult, if we didn't get enough sleep, our performance will be low and we will have daytime sleepiness. Our mood will be swing. This is the difference between adult and children. Memory consolidation, your memory, whatever, the one who's spending all the night study and go for exam, the memory, it will be less in compared to the one at least he take 4 or 5 hours before the exam. Why? Because many processes happening that, and this summarize this one, sleep and memory consolidation. We have to know that it confirmed that the sleep is essential for formation of our long-term memory. Different staging of the sleep usually related to the consolidation of type of memory. Like if we are in non-REM, it is related to remembering the idea and the fact. And REM is related to the procedural form. It's like the computer. Okay, so the one is storing, the one is releasing your information when you go to the different type. Summarizing this like computer encoding during wakefulness, we mean by that when you have releasing high acetylcholine. There is one study which is done by Kana Okano. They tried to describe the sleep quality, duration, consistency associated with better academic performance in college of a student. And they found that the quantitative and the objective evidence that better quality, longer duration, a greater consistency of sleep strongly associated with better academic performance in the college. After this study, they found that during a residency or program, they tried not to continue 24-hour performance. Why? Especially in the surgeon and also the one who have a procedure, because their performances will be less and their academic to pass the exam is less. In our Saudi Commission, based on that study, they try to give them both on call off and they will not work for 24 hours. And you notice that in your hospital. Sleep effect in our and this is related to REM and non-REM and the percentage of that. So anyone who have cardiac disease or have any stroke should be referred to the sleep lab to evaluate that. And they found that they have high risk to develop cardiovascular disease, and their immunity and inflammation and also restoration and healing also affect on their endocrine and metabolic regulation. I will show you here what is the correlation between the cardiovascular system and the sleep. I'm sure you hear that from the previous, my colleague, about the cardio, but you have to highlight that the sleep disturbance is related to obstructive sleep apnea. So if they have sleep disturbance and they have obstructive sleep apnea, it will affect on their endothelial cell. So there is a treatment for that. After you document their significant apnea-hypopnea index is high and they need non-invasive ventilation, it will reduce the need for medication. It will help their endothelial cell to be recovered, and it will decrease the risk for develop hypertension, pulmonary hypertension, and the risk of coronary heart disease. Sleep deprivation associated with increased risk of congestive heart disease and hypertension. So the one who have any medical problem, he should avoid taking long time duration of on-call or shift in the work. We'll come now to as a lifestyle medicine, obesity and type 2. We have to know there is, if they have short sleep duration in young healthy population, usually associated with decrease the leptin. Do you know what is leptin and ghrelin? This is the two hormone which is responsible for your appetite. So if you have leptin, it will be, you will have decreasing in your, increasing your appetite. And if you have a ghrelin, it will affect also your appetite. So there will be leptin, which is correlated to the lean muscle because decreasing your appetite. But ghrelin, it will be increasing. So if any defect between this increase, so you'll have more appetite, more eating, so you will have increase in hunger, appetite, and leading to overweight, then you will go for obesity. Type 2 diabetes, a study shown that the people who reported sleeping fewer than 5 hours per night have a great risk to develop type 2. And the study have also found that improving your sleep positively influencing the blood sugar control and reduce the effect of type 2. And they notice if the patient improve their sleep hygiene, not all is need intervention, and they did their sleep study or they seek the medical advice, there will be with a good follow-up with the endocrinology or family medicine, they notice decreasing in their medication and they reach to their target. This is the endocrine. I can summarize in this table. If you have repeated nocturnal sleep deprivation, and it will lead to your chronic state of sleep deprivation. That leads you to think. First, increase in your interleukin and C-reactive protein, and also prolong your waking hour. If you have like this, you will have daytime fatigueness and less exercise, and you will have glucose dysfunctioning and decrease in your cortisol, and leading to also high ghrelin and low leptin, which is responsible for your appetite. And you will have insulin resistant, you will have hormonal changing, and that will lead to obesity and the complication of it with hypertension, diabetes mellitus, dyslipidemia, and metabolic syndrome, and increased cardiovascular mortality. So if you go back to the same, it will be related to your sleep. So what is the sleep disorder? Sleep disorder is many. So I will give you just only important thing, which is the obstructive sleep apnea. Early sign of that is snoring at night. We have to keep in your mind, not all snoring is pathological unless it is affecting your breathing. It is a common in children, adolescents, even in adults, characterized usually by repeated episode of a prolonged, partial, or complete upper airway obstruction, multiple arousal from that obstructive, leading to sleep fragmentation. So anyone who's snoring, but he's not awaking at night, and he will not change his position, we can say it's habitual. And you will ask the family if they have. If the one he have frequent awakening, drying in mouth, go to the bathroom many times, this is pathological. In any way, the one who have snoring, disturb the one who's accompanying him in the bed, it's better to seek the medical advice because it is easily to be treated. Because when you have obstructive sleep apnea, it will affect in your cardiac, it will affect in your blood vessel by hypertension, it will affect your frequent arousal, and you will not get good quality time of the sleep. Other thing, we have restless leg syndrome and periodic limb movement disorder. Many people, they have this symptom and they didn't seek the medical advice. What is restless leg syndrome? It is characterized usually by uncomfortable sensation. You will notice that in the leg, and resulting in motor restlessness to relieve this symptom. Usually it will be worse at night, but in the daytime they have it. And it will be released just only when he tried to move it. You notice some people in the meeting, they trying to kick their leg, okay? This is, they need to check if it is continue with it and with the activity or under stress. So you have to check your serum ferritin because it's easy to be treated. Periodic limb movement, usually this is periodic episode, repetitive type limb movement during the sleep associated with arousal and awakening. It is different from that one. This also need to be treated. There is some medication for this. But the restless leg syndrome, usually it is like electrical sensation in the lower leg. Once he did the activity, it will be stopped and he can hold himself. Periodic, usually only during the sleep, the one who's accompanying him, he's noticed that. He's kicking him and he will be awake after that. The other thing is narcolepsy. Narcolepsy, it is relatively rare chronic neurological disorder, usually significant degree of functional impairment, and the hallmark of this is excessive daytime sleepiness. Usually they said it's occurring in adults, but now in my clinic, I found the youngest child I have is 4 years, and I have one 17 years. Early pick-up of this is very important before they diagnose them as it is neurologically disorder or it is type of silent epilepsy. But with a polysomnography, we diagnose that narcolepsy by doing for them sleep study all the night, and the next day we did for them multiple sleep latency and easily to be treated. The one who have narcolepsy, he should not take listening of driving because it's the risk for them to have car accident. And we should pay attention for that. The early sign of that, they have excessive daytime sleepiness. It doesn't mean while they are watching the TV, they will sleep. In the lecture, they sleep. Even when they are driving the car, they will sleep. It is forceful. They cannot control themselves. Sometimes associated with other symptoms, we call it catalepsy, and sometimes without it. But it is very important to pay attention for that. Since we established the importance of the sleep, we have to know how to get a healthy sleep. Everybody, they have a question. How many hours is important for me to sleep? For me, I sleep 12 hourly. The other sleep 6 hourly. The other saying I'm sleeping 5 hourly. So everybody, he can judge himself. This is the daily requirement according to the age. Newborn, usually 14 to 17 hours. It will not be continuous. No, it will be splitting by frequent awakening for around 45 minutes, 30 minutes, 1 hour. But they need like this. More of their time sleeping is the REM because it's responsible for the mental developmental. Once we grow up, requirement of the sleep is decreased because the need of the life, and it's only needed for our physical activity. Adult usually 7 to 9 hours, 7 to 8 hours. If you ask me, it's enough for me 5 hourly. So everybody can judge himself. He will say, after I slept for 5 hourly, the next day what I'm feeling. If his feeling is very active, energetic, that means he went through good quantity of the sleep. Not important for me, the quality. This is very important thing. So good sleep habit, it is referred to the sleep hygiene, can help you to get a good quality night sleep. You have to have a sitting consistent sleep schedule. What we mean by this one? If you are planning to sleep usually at 9, so keep this for 1 week. Don't make a big change over the weekend. You are get to use sleep at 9 p.m. But over the weekend, I will go at 1 a.m. and the next day at 2 a.m. Then, okay, tomorrow I have a duty, so I will go to my bed. No, don't force yourself like this. Keep the consistency of your sleep schedule. If you want to extend it, it is not exceeding 1 hour. For adults, everybody judge himself. He can make a shift of 2 hourly or not. Okay, if I will extend, I will go to my bed over the weekend at 12. So I will force myself, instead of waking up at 7, I will take 1 hour from the early morning. The other thing, preparing appropriate sleep environment. Even in the children, don't say to him, go to your bed. It should be every mother, she know her child, there is special preparation. Either he will take a warm bath, brush your teeth, wearing pajama. This is a preparation for the bed. This is very important. Avoiding factor interfering with a healthy sleep. What is the thing interfering with your sleep? The bad thing for us is our light in the bedroom. It should be dim light. The other thing, it should be no electronic device in children room. For adults, it's difficult to give this advice, but keep the mobile is away from you. The other thing, no TV in the room. There should be the curtain is covering well your window, so there is no more light because it's responsible to initiate your sleep. What is the warning sign of unhealthy sleep and overall lack of consistent sleep quantity or quality can be a symptom of poor sleep hygiene? Example, you have hard time to initiate your sleep. This is warning sign. The other thing, experience of frequent sleep awakening. When I sleep, I wake up many times. The other thing, suffering from the daytime sleeping. If you have any of these symptoms, this is warning sign for unhealthy sleep. So what is the unhealthy sleep also? Insomnia. What do you mean by insomnia? Insomnia doesn't mean you are deprived from the sleep. No, you have to know it is involved either difficult to initiate or to maintain your sleep. It is the most prevalent health problem, approximately 10% reporting of that, and 25% of they have occasional insomnia. You have to seek a medical advice to know what is the reason. Sometimes it will be related to physical problem and sometimes is psychological. But the sleep physician will guide you where sometimes you will have problem when you sleep, difficult to initiate because you will have some problem. So insomnia, it is very serious public health problem. Risk factor, it is including poor mental health. You will have illness, it will affect your lifestyle and your working condition. So setting a consistent sleep schedule, this is very important. So you have to decide in a specific bedtime that give you a sufficient total sleep time. And you have a fixed wake up time to avoid fluctuation. You have to limit your nap during the daytime. If you need a nap to regain your energy, make it short, maximum 30 to 45 minutes. Preparing appropriate environment. Like what? You have to avoid the bedroom during daily life for work or gym or playroom. Bed is for sleep only. You have to keep minimal electronic in your bedroom. Your bedroom temperature should be comfortable and cool at around 22 degrees. It's not mandatory. Everyone who will select the problem usually with the partner. If the wife like some temperature and the husband, this is the big problem. So they have to fix this issue. External noise can cause for you awakening. If you cannot keep your bedroom quiet, consider a white noise. What do you mean? If you're saying, my neighbor, he have building or they are doing something or he's nearing to the factory. So I'm asking for the white noise, like to open application and your mobile 24-hour. It is the sound of ocean or whatever, or Holy Quran. Everyone decide what he needs. Light is the most powerful Zitkiber for the circadian, and so you keep your bedroom as dark as possible. Use a well-built and comfortable mattress and pillow. That's why I'm asking the mother, let your child who select his bed mattress, what he like. Special bedroom for everyone, he will select what he needs. Not the mother, she will be the moderator of that. Avoid the thing which interfering with your sleep, like what? Avoid the caffeine and smoking. Caffeine, it could be available in our tea, in coffee, in chocolate. Make the last time for it around 2 p.m. or 5 p.m. Avoid the blue light in the bedroom. Avoid the heavy meals. And avoid the hard exercise, avoid the stress, avoid having your phone near the bed. If you have conflict with anybody, say tomorrow we'll discuss it. Don't make it at night because it will affect your sleep. So this is the tip for healthy sleep. We can say it that get the same time of waking and sleep. You have to have evening walk, bedtime routine like brushing your teeth, taking shower, whatever, relaxation, doing massage or relaxing bath, and the temperature of the room and the comfortable. The thing you have to avoid it if you want a healthy sleep is the heavy meal, the blue light, and the hard training, any caveating, any smoking, even passive smoker. If your husband is a smoker, you have to be away from him because you will be a passive smoker. And I try to make it simple as much as I can. I hope it was informative, and I'm willing to take any question.
Thank you, Dr. Nasreen. Is there any question? Dr. واضحة. عفوا.
Thank you so much, Dr. Wadha. My question is about night terror. Is there a relation between night terror and let's say also the dreams, the bad dreams, and the quality of sleep that might also affect the metabolic indices? Thank you.
Thank you for your question. This night terror and this is nightmare, usually it's happening in the children. Genetic factor is playing a role for that. Usually just only if he's younger, the advice is going to the mother. It will affect on the quality and the quantity of the sleep. Just only need reassuring. Don't awake him when that is happening. Just only the daytime, the last 24 hours, you have to review. Is he seeing scary moving? There is a stress at home or anything. But need reassuring. Once it's happening, don't move him from the bed, leave him, just wrap him and keep him on the same time. Usually associated with some metabolic disorder in children, but usually it is a genetic and affected some children from the culture and the environmental. No special medication for that. Some they try to take some sedative medication, it's contraindicated.
Shukran, Dr. Wadha. Nice presentation. I'm happy to see you here in this conference. Probably we'll see you in other conferences. And to get you ready, there will be a dedicated conference to only sleep, inshallah.
Inshallah.
Just sleep with obesity. I just want you to comment on, and there is a lot of studies showing that people who have chronic lack of night sleep, they have increased inflammation, increased progenitor cells, that's fat cells, and increased fat deposits in these fat cells, which leads to a lot of obesity, and especially in our society. And any research, local research in this area, and what is your opinion on it? What we can do? That's a big question. What we can do to improve that, inshallah.
Awareness, we are trying to do awareness day for the family, for the mother about that. Now we'll try to collaborate with them. Actually, I did only the research for correlation between affecting and some hematological disorder like sickle cell anemia. Usually, even if they are very slim, they have obstructive sleep apnea, it's correlated. I did a paper on that and already published in good journal. But for the obesity, we have usually all the obesity referred to my clinic secondary to the syndromatic. And we did that for especially Prader-Willi syndrome. And usually the mother insists because, you know, they have problem in their mentality. They did for them gastric sleeve. And we found a rebound phenomena for gaining the obesity, it's happening. So I advise from my paper, all the Prader-Willi syndrome, they should not go for gastric sleeve. And we found many cases in the Western, it is a lifestyle medicine. The problem, the mother, they found they are handicapped children, difficult, so give them whatever they want, so leave them to be calm. This is my future research about how to convince them. There is no indication for gastric sleeve to avoid the obesity. Morbid obesity, to be honest, it is the duty of the family medicine. All they said, okay, and I remember one child, he's 10 years old, body mass index for him, it was 60. And the mother mentioned the surgery refused to do for him gastric sleeve. We advise her to go to the nutrition. I start him on CPAP and they say, she wants him to reach more than this one in her mind, and she convinced the child only gastric sleeve is the solution because I did for myself. But we need to educate the family about this one because they found after that we will do the exercise. Many and highly educated family, they are doing the same. It is good, we can do the research for that, but I think all the community is from adults.
Just a follow-up on obesity, this is just a comment. We advise against having gastric sleeve for teenagers, especially syndrome, Prader-Willi syndrome. And I did see in my clinic, a lot of them rebound. And I remember one father, actually, you know, if they throw their عقال and shmag on the ground, that is trouble. Yeah, so remember this. So against my advice, the father insisted his daughter, she was 13 years old, to get gastric sleeve. She was morbidly obese. And I told him, I don't advise it, and I'm sure he will be sorry later. So what happened is he went and did it, and she had the surgery. Within 3 years, she's more obese than she was before. And he was so ashamed, he will never come to the clinic with her anymore. Somebody else would come. So if you get patients like this, please, you need to advise. They are not mature enough even to understand what to do afterwards. Adults have struggled changing their behavior. So lifestyle interventions, and we have to work on the mindset management. Al-aqeedah, al-fikr, it drives a lot of people. You've seen a PhD who's worshiping a stone. That's a mindset problem. Stone doesn't do anything to you. You could break it, but you know this. I don't want to delve into this. But what people believe in, their thoughts, their beliefs, their practices, really affects, you know, their health outcome. And this is one area in lifestyle medicine that regular medicine doesn't really cover, which is your mindset and also mindfulness. Mindset, al-aqeedah bil-Arab. Mindfulness, اللي هو الإحسان. So remember these two things. I use it with my patients and they're very effective. Shukran.
Thank you, Dr. Saleh. Is there any question?
الله يعافيك دكتورة واضحة. السؤال كيف الواحد يصل لمرحلة الرم اللي في النوم لما يكون مثلا النوم تبعه ما هو يعني ما مش عالي، أحيانا يكون أوقات قصيرة، فكيف يعني نقدر نصل هذه المرحلة؟ هذا السؤال الأول. الثاني بالنسبة يعني للأطفال حتى المراهقين، أحيانا أكثر الأمهات يشتكون إنه مثلا ينامون كويس بس الصباح مشكلة، لسه يقولون لا نبغى ننام يعني. فكيف يعني الموضوع هذا الصباح حتى لما يصحى يكون مرة تعبان، لسه ما النشاط ما وصل عنده، فهذا الموضوع كيف؟ هل هو له دخل بالنوم أو لا؟
Yeah, all of this, thank you for your question. All of this is related to your sleep hygiene. The one who will go for the REM, the one who have physically exhausted in the daytime and he didn't get the nap, and like he did a good routine daytime and he wake up on the early morning. You cannot ask the one who sleep all the daytime, then force to go at the bedtime while he spent all the time is sleeping, and you want him to go in REM. He will never go in REM. How you know? Nobody can ask he go in REM or non-REM. This will appear in the sleep lab from the polysomnography graph, but how you will know from his activity on the next day? How is the activity? Like the one who's sleep deprived, like nursing or security or حراس الحد الجنوبي. Even you as a physician, if you wake up at 5 after Fajr and you wake your kids and you go to your work and you go to your bed at 8 o'clock, you wake up energetic at 5, I'm sure you go to the REM 20 to 20% of your sleep. How you know that? From your mind. You feel you don't have headache, you feel energetic, you want to do the exercise, you feel you are powerful. This is indicate for you. For the children, because the mother forced them to go to the sleep, but what he's doing in his bed, I'm sure he didn't go to the sleep. Only on the latest hour after Fajr, the late night, maybe he go to the slow wake stage of the sleep, non-REM, then khalas, you have only 2 hourly. Children in this age, they need 7 to 8 hours of the sleep, and he will be swinging from REM and non-REM. How the mother know that? From his mood in the next day. النوعية حقت النوم ما كانت كويسة فترة طويلة. في ناس مثلا تجيك تقول لك I slept for 12 hourly لكن ثاني يوم أصحى غير نشيط. شخص آخر نشيط، معناتها ما لها دخل بالكمية، لها دخل بالنوعية. أحيانا is it not go, you will go to non-REM stage 1, stage 2, stage 3, then you will go for REM. No, if you are sleep deprived, like when you have shifting at night or you have a jet lag, once you go for sleep in your bed, you will go immediately to the REM because your body and mentally is needed. So you will go to the REM for around 30 to 90 minutes. Then after that, you will go for a slow wake stage, non-REM stage 3, which is important. The important thing, you will go for REM for mentally because you are already exhausted. Okay? فالإنسان هو حكم نفسه. كيف تتحكمي في هذا الشيء؟ ما نقدر نغير like what happening in رمضان. طيب رمضان شوال دائما الناس مكتئبة، ثاني يوم ما حد يكلم أحد، صح ولا لا؟ and you feel nausea, vomiting, seeking medical advice. الأطفال عندهم vomiting. كل هذا لها علاقة بالهرمون الميلاتونين. we trying to shift our circadian rhythm. we are forcing our brain to shift it. إيش المطلوب؟ العشر الأواخر أو أول يوم العيد نسحب 1 hour 1 hour. مثلا متعودين ننام بعد الفجر، نحاول هذاك اليوم نمنا بعد الفجر ما نصحى، مثلا نصحى العصر، نحاول نصحى مثلا بدل ما نصحى الساعة 3 نصحى الساعة 2. اليوم اللي بعدها نسحب ساعة ثانية بالتدريج بالتدريج. This is brain. There is a pacemaker for that. There is a stimulant. غير كذا الكلتشر كله ما يكون في مثلا نوزي. كل الفاميلي يبدأون بنفس الشيء. احنا صراحة للأسف دخلتنا الحضارة وأخذنا السلبيات أكثر. يعني you never find a house في الرياض ولا ما أعرف عن حائل، إن شاء الله حائل أحسن مننا. الإضاءات الثريا هذه شيء ملفت للنظر. This is affect in your circadian rhythm, affected in your sleep pattern. فلازم تكون إذا في ثريا ما عندنا مشكلة، خلها في غرفة الضيوف وميك a dim light around it. طيب الليفينج روم اللي نجلس فيها من بعد صلاة المغرب تكون إضاءة خفيفة. try to stimulate البرين. العشاء ما يكون في عشاء ويكون في عشاء خفيف، يكون في high protein carbohydrate, no more sugar and fat. I hope I answer your question. There is one question here. آخر شيء.
Now we take the last question. Now, thank you, Dr. Wadha Al-Ataibi. Now we have a break for 1 hour. Okay, thank you.
السلام عليكم، مساء الخير جميعا، يعطيكم العافية. نحاول طبعا نكون maximum to 15 as a maximum in this session. Our next speaker, Dr. Khalid Al-Jaber, his lecture about the effect of lifestyle on the psychological well-being. Dr. Khalid is a consultant family medicine and psychotherapy, and he is a famous one. Welcome with me for Dr. Khalid, and أهلا وسهلا بك في حائل دكتور.
ما أدري إذا ممكن اللاقط لا اللاقط إيه ممكن هذا. طيب بسم الله الرحمن الرحيم. طيب أنا بحاول إن شاء الله إنه يعني within allocated time for me 25 minutes إن شاء الله قدر المستطاع بإذن الله تعالى. طيب the effect of lifestyle and psychological well-being. فبسم الله الرحمن الرحيم. What is lifestyle? What is lifestyle? Classical way of defining lifestyle, which is the 6 pillars as one model of them: healthy diet, drinking, exercise, sleep, إلى آخره. لكن what I'm trying to talk today is in a bit different way, where can we go more deeper instead of lifestyle, style of living, style of living, how we see life, how life lives in our heart. Will this affect really our lifestyle ولا لا؟ وكانت القصة اللي يعني أتكلم عنها، القصة اللي قلتها الصباح اليوم، قصة الصحابي اللي بعد إسلامه تغير في خلال 24 ساعة، تغيرت طريقة أكله، والسبب إنه هو أصلا مفهوم الحياة كلها تغير عنده، مفهومه هو عن نفسه تغير عنده، أشياء كثيرة تغيرت. هذا اللي أقصده أنا، إنه this what I meant when I say this morning that to have an effective approach in lifestyle, I think we have to go in a deeper level, in a deeper and in a higher level, rather than just individual, technical, tactical, basics, practical skills. What is the style of living? What are our views of the good life? How we define happiness? What's our definition of success and achievements? هذا برنامج أنا قدمته عدة مرات خلال السنوات الماضية for the public. اسمه، أعطيته اسم النفس الطيبة. النفس الطيبة هو من 5 محاور. أحد المحاور واحد منهم عن اللايف ستايل أو الستايل اوف ليفينج. و the idea إنه if we define life properly, if we define happiness properly, if we define success and achievement properly, I think this will help us in practicing a healthy lifestyle. هذه خلاصة محاضرة اليوم. بعيد أقول repeat it in Arabic. خلاصة المحاضرة إننا إذا إحنا نعرف إن إحنا نواجه مشكلة كبيرة جدا في إقناع الناس وإقناع أنفسنا في السلوك الصحي. ليش؟ لأنه ترى إحنا الأطباء والقطاع الصحي عموما إحنا مثل المشايخ. يعني شوف، حفت الجنة بالمكاره وحفت النار بالشهوات. المشايخ نفس الشيء، يقولوا للناس هذا حرام وهذا حلال وهذا صح وهذا غلط. في أشياء كثير الناس ما تجوز لهم لكن يسوونها لأنها حلال وحرام. نفس الشيء إحنا نقول لهم ترى في أشياء ما تصلح لك للصحة، ما هي كويسة للصحة، ما هي. فإحنا we are against their own definition of happiness and pleasure and success and achievement. طيب, if we manage to change their own definition of happiness and success and achievement, I think our mission will be easier. عفوا يا أخوات الصوت بس. فإذا قدرنا حنا إننا نغير تعريفهم للسعادة، للحياة، مفهومهم للحياة، مفهومهم للذة، مفهومهم للنجاح، هذا بيساعدهم هم وبيساعدنا حنا على إنهم to practice a healthy lifestyle. هذه خلاصة محاضرة اليوم. What are our views of the good life? How we see life, how life lives in our heart. So this definition is our campus, our guiding campus. هي البوصلة اللي توجهنا إلى هل نتخذ فعلا القرار. وأنا I will tell you a personal story. قبل كم سنة جتني gastritis. الجاسترايتس هذه فجأة كذا ما أدري شلون، وله علاقة كنت أرمم البيت وصالات عمال وما عمال، أي واحد منكم جرب ترميم بيت ولا شيء، فالجاسترايتس يعني imminent على طول. شفت ترميم البيت والعرس، أم العروس بالذات ولا أبو العروس يعني يدفع قروش بس ويكبر الوسادة، بس أم العروس اللي حالته حالة وخبه على وشه على الحلقة طلع زين ولا ما طلع زين. خل البنت تتوفق كيف الحلقة كيف والحلقة، بس خل البنت تتوفق ولا باتي كيف. فجت جاسترايتس واضطريت اضطرارا، هذه مهمة صالح، اضطريت اضطرارا اني اخذ هيلثي دايت لمدة 6 شهور. وجدت انه بكل سهولة قدرت اضبط نفسي. ليش؟ لأن عندي درايفنج فورس. صار مفهومي أنا، هذا اللي أقصده هنا، صار ماي ديفينيشن الآن ما هو بالبليجر، هذا صار ماي ديفينيشن البليجر الأخير اللي هو إنه يروح البين. ولذلك فلاسفة الإسلام لما تكلموا عن اللذة، مفهوم اللذة والألم مفهوم قديم من قبل، من أيام من قبل أفلاطون حتى، بس هم قالوا أضافوا مهمة فلسفية، قالوا إنه أنت يجب أن تنظر إلى اللذة باعتبار عامل الزمن، يعني ليست اللذة الآن الحالية لكن اللذة بعدين. هذا اللي صار معي بالضبط أنا، إنه أنا لما كانت الجاسترايتس كنت أنا أنظر لذة بعيدة وهي لذة زوال الألم. If we manage to tackle this, to work in this area، نغير الديفينيشن حق الناس للبليجر والهابينس والاتشيفمنت والسكسس واللايف كله، هذا بيساعدهم اكثر ويساعدنا احنا على انهم to practice lifestyle. How life should be lived. يعني مثلا مستحيل you cannot convince somebody who believe that انه material pleasure is the only definition of happiness. شخص يعتقد انه المتعة المادية هي التعريف الصحيح للذة، او شخص يعتقد انه money equal to happiness، هذا مستحيل تقنعه يسوي لايف ستايل. He will not change his lifestyle لأنه أصلاً هو عنده definition عالي فوق. He has a higher definition. What is happiness? What is pleasure? What is achieve success? What is good life? Definition of good life. We will go through different terminologies. Most of them are Islamic, translated to English. بحاول إن extravagance اللي هي الإسراف والتبذير. Asking for more, spending more, 7-star life. ترى 7-star هذه 7 stars only recently يعني released in the last few decades. And for me it alarmed something in my mind. You know, يعني people they were looking for 1 star and then 1 star is not enough. So 2 stars are not enough. Then 3 stars are not enough. Then 4 stars are not enough. Then 5 stars. 5 stars are not enough. 7 stars. So if you increase the stars, the numbers of stars, this will not satisfy human being. They will crave for more. They will crave for more. And this is why healthy lifestyle is very difficult nowadays. life, looking for 5 stars life. If they redefine what is the good life, it will be easier for them and for us to practice a lifestyle. Welfare entitlement, سميتها أنا استحقاق الرفاهية. welfare entitlement، استحقاق الرفاهية، إنه وهذه كثير فلاسفة يتكلمون عنها، إنه لما تصل البشرية when the humanity reach a point that a higher level of welfare and luxury is entitled for every person, then nobody will be happy. Nobody will be happy at the end, because we know that this cannot be achieved. We know by fact this cannot be achieved. مستحيل كل الناس يصيرون رفاهية عالية مرتفعة جدا. فأنا سميت هذه استحقاق الرفاهية. إنه many aspects of life have become among the inevitable necessities، الضروريات الحتمية التي لا يمكن الاستغناء عنها. هذه inevitable necessities هذه it's a real problem. يعني its circle become increasing with time. الضروريات الحتمية في الحياة صارت تكبر دائرتها مع الزمن. لما when this inevitable necessities in life increase, then most of the people in the community cannot afford this necessities. ما يقدرون يحققون، فيحسون they will believe إنه they are below the level of standard, and by this they will not feel happy, and by this they will not practice healthy lifestyle. In housing, clothing, fooding, travel, transportation versus consumption, many things. The problem is that the higher the welfare entitlement, the more expensive the happiness becomes. يصبح سعر السعادة أغلى. أنا بسوي دعاية. ولدي تخرج من الجامعة قال ما أبي وظائف، فتحنا له محل كافي. هو قهوجي بس يسمي نفسه باريستا، وأنا ما بناديه إلا يا قهوجي. بس صراحة شغله زين، برسل لكم بعد شوية الرابط حق أنا الولد ذكي جدا على أبوه طبعا. فأنا أسأله أقول له الناس الحين من اللي يجي يدفع 17 ريال على كافي ويقدر يشتري مثله بريال، يحط له نسكافيه وحليب وقضينا. قال البركة، شوف عبارته، قال البركة بالميديا. البركة بالميديا. الميديا هي اللي خلت الناس تبين للناس أنا قهوة الصباح، أبدأ صباحي بالقهوة، ويحط قهوة من الغاليات. فخلاص ينتشر عند المجتمع إنه this is the standard. هذا النورمال اللي كنت أتكلم عنه الصبح اليوم أنا. هذا النورمال صار الآن. النورمال إنه يكون عندك مطاعم وتكون عندك سيارات ويكون عندك. طيب بس هذا this is not real normal و not healthy normal. إلا عاد القهوة، قهوة محل ولدي بالذات هذه ممتازة. vortex of consumptions، دوامة الاستهلاك. vortex of consumptions. الناس تحول البشر إلى مستهلكين for nothing, just for the base of consumption. الناس صاروا يستهلكون فقط for consumption, just for consumption. تروح مثلا الآن صارت الملاهي بالأسواق. ترى هذه حيلة. العثيم قابلوه مرة فذكر الحيلة، قال احنا نسوي حيل عشان الناس يشترون، فنحط الاشياء غير المرغوبه في الاخير، عفوا الاشياء المرغوبه نخليها في الاخير، عشان لين يصل الله يكون مر له على 50 صنف وهو رايح وهو جايب لازم يشتري شيء. simplicity or complexity. Life becomes so sophisticated. Complexity is a source of stress. Running short of breath. نلهث. Short of breath. الناس يركضون running for the run. We need the programs of serenity, sakina. We need programs of calmness, of contentness, الطمأنينة والراحة والهدوء. على الغداء اليوم كنا نتكلم عن القيادة في السيارات، كيف انها اصبحت a source of stress by itself. And how to help people to live with in this half an hour or 1 hour in the car without stress. هذه ترى nothing. انت بالسياره جالس وعندك ستريس عشان واحد ما يعرف يسوق خطم لك، ولا واحد طنب لك، ولا واحد وقف قدامك، ولا زحمه، ولا الاشاره ولعت 10 مرات وانت ما تحركت، ولا هذا الان الستريس بيرسون. تتوقع دكتور صالح وبقيه الزملاء توقع انه الاسبوع الجاي بيسوي لايف ستايل زي الناس؟ ما هو برايق اصلا، انه بالعكس يبي يحط حرته بالاكل. he will release the stress by doing more eating. He will release the stress by more relaxation. He will relieve the stress by fighting with everybody. It's highly connected. Simplicity is the elixir of serenity. اكسير السكينة. كل ما كانت الحياة أبسط. وذس شوفوا يعني البساطة ليس معناها انك تصير ثيابك وسخة وحالتك حالة ورثة، لا، تصير بسيط. ما في داعي انك دائما looking for 7 stars 5 stars 4 stars. لما ذاك اليوم ما تلقى حجز الا بفندق 3 ستار تقعد متضايق، والاجازة متنكدة، ولا استمتعت بالاجازة. ليش يا اخي؟ ليش؟ إذا طلعت من المطار وشفت السيارات صافين، سيارة ب50 ريال وسيارة ب500 ريال وسيارة ب100 ريال، فأنت تقنع نفسك إنه السيارة 150 ريال أحسن لك من السيارة ب50 ريال. أنا أضرب أمثلة فقط للتشبيه، ولكل واحد هو عنده مقاييسه الخاصة، بس دائما حنا كل ما طلبنا أكثر، كل ما كان قدرتنا على تنفيذ الهيلثي لايف ستايل سيكون أصعب علينا. لأن الهيلثي لايف ستايل هي باختصار هي إنك تحرم نفسك من أشياء أو تمنع نفسك من أشياء موجودة، لكن أنت تمنعها لأنه في مصلحة لك أنت. يعني مثلا اليوم على الغداء ما كان في حلا، صح؟ هذا النورمال إنه ما يكون في حلا أصلا، لكن هم أقنعونا إنه لازم حلا مع الأكل. من اللي حط القانون هذا لازم حلا مع الأكل؟ لما ما حطوا حلا على الأكل اليوم، أكلنا متنا حنا أسبوع أسبوعين نتعود وخلاص ينتهي الموضوع. هذه هي الفكرة، إنه إذا حنا if we are looking to change behavior of people على الليفل of individual وتاكتكس، بدون ما نشتغل على الهاير ليفل والcollective it will not work. This approach is one of the way that we have to work on people to redefine the things, the basic things. Redefine the basic things. Source of happiness. Source of happiness. How happiness is defined. مرة كان عندنا مجموعة واتساب، مجموعة من الزملاء كلهم أطباء ويعني ممارسين صحيين، فبين وقت كذا يعني أرسل لهم أشياء زي كذا، قلت لهم وش تعريف السعادة؟ وش تعريف السعادة؟ يعني كلام الفلاسفة قديم، تقسيم السعادة إلى يعني أنواع كثيرة، هيدونيك ويدوميك وما أدري إيش إلى آخره، لكن في ناس كثير ما يعرف كلام الفلاسفة، لكن عنده قناعة معينة إنه السعادة إنه to fulfill the current and now needs and greeds. إنه الآن أنا أبي آكل، أبي أشرب قهوة، أبي أنسدح. معلوم أنسدح يعني أنجضح. صعبتها أنت الأول، أسهل أضطجع. ففي ناس كثير، أنا أذكر كذا مريض عندي في العيادة تجي عندها ديبريشن مثلا. ليش ديبريشن؟ أنا فقيرة. طيب آمنا بالله، بغض النظر هل هي فقيرة فعلا ولا لا، يعني كثير منهم أصلا ما هو فقير، بس هو يرى أنه فقيرة. ليش فقيرة؟ ليش؟ طيب أنت الآن وش تقول؟ هي تقول أنا ما أقدر أسوي اللي الناس يسوونه، أنا ما أقدر أسافر زي اللي الناس يسافرون، أنا ما أقدر أركب سيارة زي اللي الناس يركبون، أنا ما عندي بيت زي اللي عند الناس بيوت. مع أنه طبعا بيتها هي وسيارتها هي وسفرياتها هي أحسن من 90% من البشرية، طبعا إحنا عارفين الشيء هذا، لكن هي تتكلم عن 10% اللي هي تقارن نفسها بهم. هذا الآن هل يستطيع أنه يسوي لايف ستايل؟ هو أصلا ما هو براضي ستايل، لانه اصلا مفهومه للحياه مختلف. Healthy lifestyles, if you have a wrong definition of happiness, you cannot do a healthy lifestyle. If you have a proper definition of happiness, you will do a lifestyle. What is the proper definition of happiness? How we enjoy our life. We have to differentiate between happiness and pleasure. Pleasure is the instant satisfaction of needs and greeds of the self. That's fine. That's fine. So eating, fooding, dressing, sex, anything, that's fine. But what is not fine, that you make this the only definition of happiness. You make it the only definition of happiness. Then excitement, raising adrenaline activity. لو تلاحظون الآن شوف الإعلانات في الشوارع، شوف صورة الإعلانات، واحد طاير، واحد رافع رجله، واحد مفحط، واحد بيطير، كل المتع، كل التسويق يدور حول الفكرة هذه، فكرة الإكسايتمنت. فكرة الإكسايتمنت. فكرة الإكسايتمنت هذه تتعارض مع اللايف ستايل. وش الإكسايتمنت اللي موجود بالسلطة؟ ها؟ ترى نهك على انفسنا، ما في اكسايتمنت. احنا ناكله ليس لانها اكسايتد، ناكله لانه في بليجر بعدين بيجي انه على الهيلث. فانا لازم الناس يعرف انه excitement is not the only way of happiness. By this and only by this he could do the healthy lifestyles. The ratio of non-material happiness and material happiness. Religion وhumanities مهم جدا انه نوسع دائرة السعادة. وانا ذكرت هذا في كثير من محاضراتي انه لازم نوسع مفهوم السعادة، مصادر السعادة. اذا انت حصرت السعادة في مصدرين بس تتعب في الحياة. You will lose the enjoyment of life. You are not enjoying life if you restrict yourself on limited definitions of happiness. The additional burden, the hostile striving of success. الضجيج والصخب الذي يصاحب النجاح. During the last few decades, in courses and workshops, they were talking about success, النجاح، تطوير الذات. كان واحد منهم يقف قدام الناس يقول: أنت تستطيع أن تكون مثل سليمان الراجحي، فقط كن عازما وخلاص وتصير. ما أنا بصاير مثل سليمان الراجحي. تلعب، ما في بالعالم كله ما في إلا 5 من سليمان الراجحي. أكيد أنا لن أكون ولا موظف عند سليمان الراجحي. ليش نلعب على الناس؟ إحنا نعطيهم we raise the ceiling of expectation and success. زوجتي حضرت واحدة من الدورات، كيف تكونين امرأة ناجحة، الكلام ذا قبل 20 سنة. وراحت قلت لها روحي، يلا راحت وجت قالت حسبي الله على اللي أنا بقايله. قلت شلون؟ قالت قامت المحاضرة تقول يلا كل واحد منكم عدد نجاحاتنا. طبعا هي معلمة، فقالت أنا أم ناجحة وزوجة ناجحة وبنت ناجحة. فالمدرب نظرت قالت لا مو بنجاح ذا. ايش تبي نجاح؟ قالت لا اعطيني نجاحات ثانيه. انا ام ناجحه وزوجه ناجحه وبنت ناجحه واخت ناجحه. فعلا هي اخت ناجحه، هي ام خواتها. لا لازم يكون نجاح مختلف. شلون نجاح مختلف؟ فحنا لما if we raise the burden on people on how to become successful. In fact, what we are doing, we reduce the level of successful people. We decrease the number of successful people. لأنه في النهاية سيقل عدد الناجحين. This working life ratio, the level of a hustle in working life versus the level of stillness and calmness. كل ما كانت الحياة running out of breath, running every day is running. You will not find a time and a calmness to do a lifestyle. But if your life is fulfilled with stillness and calmness, الهدوء والسكينة والطمأنينة, then you will find these issues اللي يسمونها الناس سلبي، وما الناس مش خرابيط مشي وتر. ليش يسمونها خرابيط؟ ولأن عنده هو تعريف له هو خاص في النجاح والهابينس. لكن لما تكون حياته stillness وكالمنس، يكون جزء من هالستillness والكالمنس هذا يكون جزء منه الهيلثي ايتينج والهيلثي لايف ستايل والجود ريليشن شيب والستريس مانجمنت. This is the idea, the whole, which comes first, obtaining peace and psychological comfort or obtaining more money. أنت ممكن تشتغل بالليل والنهار. And you could earn more money. That's fine. But will this give you a peace and psychological comfort? لازم أنت توازن في حياتك. أنت وش تطلب؟ يعني الأولين وش يقولون؟ أكيد تعرفون المثل المناسب هنا. الراحة نصف القوت وهم صادقين. The last slide. Why this slide is this topic is very important. As I explained, I will repeat it. That style of living is as important as healthy technical lifestyle. Style of living change our psychological characteristics such as patience, contentment, endurance, and strength. يعني إذا كان نمط الحياة بالطريقة اللي قلناها، تعريفنا للحياة صحيح، تعريفنا للسعادة صحيح، تعريفنا للنجاح صحيح، تصير قدرتنا على الصبر أقوى، قدرتنا على التحمل أقوى، وبالتالي نستطيع أن نمارس سلوكيات الحياة الصحية. هذه هي الفلسفة اللي أنا أحاول أنشرها قدر ما أستطيع، إنه القضية ما هي فقط إنه والله changing card و how to change your behavior or become a healthy lifestyle. It's more complex than this. The ceiling of our expectations, سقف توقعاتنا, the ceiling of our expectations of life largely determines our level of satisfaction and conviction. الرضا والقناعة معتمدة بشكل كبير جدا على سقف التوقعات العالي. كل ما ارتفعت النجوم كل ما قل تنفيذنا للهيلثي لايف ستايلز. والبروسيس معروفة. Our concept of success, achievement, effectiveness greatly and directly affects our psychological health. Thank you. والله ما أدري التزمت بالوقت ولا لا، لكن إن شاء الله.
يعطيك العافية دكتور خالد. very informative صراحة، nice presentation وقريب صراحة. فاحنا ودنا نعمل كذا discussion، يعني ناخذ صالح.
الخير دكتور خالد. I'm just while you're presenting the definition of the proper lifestyle, I think this is you opening doors, and I'm thinking while you're talking, and we need courses just on the definition of lifestyle itself and life and living and definition of happiness, and I think probably we should include it in our future conferences more. And I agree with you, definition of happiness is very important. And مثال انه انا اجيب مثال الشنطه ب50,000 و50 ريال.
لا بيزعلون الحريم علي.
لا ما يزعلون، يوفرون قروش. هي فانا اقول لهم واتس ذا فانكشن، يعني وش فائده الشنطه؟ تجي الوحده يعرفونها البنات هذه اللي قيمتها.
لا صالح اعطي عشور يحط مثال على الرجال.
لا خليهم مثال. الحين اللي قيمتها بشنطتها وش تسوي؟ يقول لك لا جت العرس ولا شيء، تحط الشنطه هي اللي قدام وهي اللي ورا الشنطه. زين. ايش
دراك انت معهم؟
لا عندي بعدين لو تشيل الشنطه هذه، هذا سيلف وورث الحين قيمتها الشخصيه. لو تشيل الشنطه، المراه اللي قيمتها ما هي بشنطتها ما يهمها، الشنطه جت نسيتها ما جابتها معها عادي ما تفرق معها. لكن if her self worth and happiness is built on اللي هو جوهرات او الشنطه او غيرها ما تهم هذه، اللي ما هي سيلف وورث، ما هو في هذولي ما يهمه. جت شنطه ب 50 ريال ولا 200 ريال، طالع مع البامه لقيت ذي تلقاها مبسوطه داخليا. It's inner peace, inner happiness. ما له دخل بهذا. انا دائما اسال، خاصه لجتني ناس هاي ديديكيتد، اقول طلعتي فستانك مشقوق ولا شماغك مسحوب منه كم خيط ومبين، تروح عادي وانت مبسوط؟ I'm trying to measure their level of consciousness about are they really enjoying where they're going to or not. يعني هذا very important. I think defining happiness is really يعني مرة السعادة هذه مهم جدا، ومع الأمثلة بحيث أن الإنسان يستعيد التحكم سعادته هو بنفسه. الناس ما يتحكموا فيها. يعني هذا مثل الكوب القهوة أبوه 60 ريال وبريال، أنا أقول القهوة بريالين، أنا أغلط شوي من الدكتور خالد. وش الهدف من القهوة؟
ينافس، لا حقنا زين أطعم.
فهي it's how you look at it when you train patients, and I think it's legitimate questions تسألهم وش تعرفين في السعادة. يعني الحين عندنا مع القادة هذا يبغى لنا شيء ثاني بعدين نتكلم عنه، لكن excellent. أنا أقول we need to probably look into this, and also in the course we recommended to have it more details. يعمل هذا.
يعطيك ألف عافية دكتور خالد. Again, a very inspirational talk. It raised the question and the comment more than the theory, and I do believe you may give this lecture over hours. I may differ in something, if you allow for me. Yes, I am with you totally that we have to talk to public at this level and redefining the السعادة and lifestyle and so on. But maybe with an individual level, with a detailed history taken inside the clinic between the very good relation between doctor and patient, you may find people are different and you accept this difference. For example, I disagree with this السعادة في طبق السلطة. Many people are finding سعادة في طبق السلطة. And many people can invent في طبق السلطة. Many people are finding سعادة في exercise. Many people no. They do exercise by obligation because of long term, but many people really their happiness inside while walking. For me, I'm an Alexandrian from Alexandria. When I'm walking on the يعني shore of Alexandria, this is my best moment all the life, without looking for body weight, without looking for cardiovascular or whatever. I mean, we have to again, beside your message, but stress also on individualization. This is one thing. My question for you, what do you think if we allow, like in Western, in USA and European Center, because I'm reading them about intensive lifestyle therapeutic protocols. They have like residential houses, very top 7 stars, by good money for sure. But they spare people outside of all these stresses which you mentioned, like for 2 weeks, 1 week, 1 month, whatever, as per everyone capability. And then البساطة بقى زي ما حضرتك شرحت gardens, water, spa.
Simple life.
Yeah, going back to nature and just taking group therapy together, exchanging stories. What do you think of this approach, like a short-term anti-stress, and then go back to your normal life, but you keep in touch with this center whenever you need them, they can support you?
بالنسبة للسؤال الأول وأنا أوافقك. I totally agree. The second question, really, I don't know, but it's really interesting that can we have a very condensed courses? But what I know from human beings and how psychological changes happen, I'm not sure will this work or not. والله interesting to be tested. Yes, interested to be tested. لا نوديهم من الدهنة خليهم يضيعون بس معهم ايش اسمه GPS، واللي يرجع حي يعطينا الفيدباك. الاستاذ كان احد رافع ايده؟
مرتين دكتور ترى. طيب يلا.
On the business side يعني this is a big topic، بس احنا قسمان عاد كلمة حول القروش والدراهم يعني ما. أنا business side there is opportunities في حائل وغير حائل، لكن حائل فيها opportunities كبيرة جدا. الدكتور أيمن يقصد إنه مريح الوضع هنا، الناس لطيفين، الجو عليل، والأماكن فيها متعة، بس تمشي برا يعني لو تسوق خلال محافظات حائل مرة ممتع. I think there is a way. I think we are in the planning، بس مع الجمعية طبعا. ربطكم مع الجمعية العلمية لطب نمط الحياة. إن شاء الله لعل يجينا خبر، ندعونا يجينا خبر جميل بكرة إن شاء الله تعالى.
يا الله.
وبعدين احنا دكتور خالد إن شاء الله بيصير بيننا تعاون كبير جدا من ناحية الكورسات، سواء لكم مباشرة أو الأشياء اللي تستفيدون منها في العيادات علاج المرضى. والباب مفتوح طبعا. أنا لو أقول لكم من رؤيتي الماركت is huge وأغلبها غير مغطى، وأنا مثل الدكتور أحمد فطاني يعرف الموضوع هذا عن كثب يعني، وعندنا الدكتور محمد الحقباني يعرف الموضوع هذا عن كثب أيضا، وكلهم مهتمين. وكان عندنا نقاش عن البزنس اوبورتونيتيز، وفي نفس الوقت أنا أقول أو ايش أقول دين ودنيا. تمام.
حج وبمثال.
حج وبعتبر.
دكتور أيمن ذكرت شيء يمكن له علاقة بالفكرة هذه، فكرة إنه كورسز. أنا أسوي كورسات للناس للببليك في الOCD والدبريشن والانكزايتي والسوشيال فوبيا، وبعض مثلا وناوي ان شاء الله بعد رمضان بس واحده عن التحرش الى اخره، يعني ضحايا التحرش كيف يطلعون منها. الشاهد هذه برامج اونلاين على مدى 4 أسابيع، كل اسبوع جلسه فيها فيدباك كثير جدا. انا لاحظت انه الفعاليه عاليه جدا، اكثر بكثير ما كنت اتوقع. انا كنت اقول يمكن 20% 30% فعاليه، لا الفعاليه ممكن توصل 50%، وهذا يعتبر رقم كبير جدا. يمكن similar approach، انه هل ممكن احنا نقول للناس تعالوا يا اخوان، ما احنا محطين لك اسبوع وانا محطينك بحايل، نحطك وانت بديرك، لكن نتفق احنا وياك على شهر نساعدك كيف انك تاخذ اللايف ستايل بشكل صحيح. يمكن تكون هذه opportunity، يمكن. وترى ما في حقوق طبعا، اللي بياخذه ياخذه.
الله يعطيك العافيه.
شكرا.
والله ما ودنا نتخلص.
الله يسلم عمرك.
ماني مخلص الا ترى اللي يصاد انا، وترى ما في يسمعك هو اونلاين. يقول احد الناس محتاج بالبابليك، هذا الدكتور صالح معنا، يبي بس محاضره اي وقت مناسب لك اونلاين. معلمين ايه خلاص جزاك الله خير. هذا عطانا وعد الدكتور ما قصر. نبي نمر الكافي. ابشر. اور نفس سبيكر مسك الختام دكتور أيمن سحيباني. He will talk about Campfire talk practice-based national research network for public health, population health management, lifestyle medicine. Dr. Sahibani is working as a preventive medicine and a public health physician and epidemiologist and director of the technical affairs in Riyadh, Saudi Arabia, as well as and the acting director of professional classification and registration. Welcome with me for Dr. Sahibani.
Assalamu alaikum. First of all, I'd like to thank the organizing committee, Dr. Farhan and Dr. Saleh, for inviting me. They will be talking about the practice-based national research network for public health, population health management, lifestyle medicine, and complementary and alternative medicine. So this would be my outline. So the practice-based national research network is built upon collaborative, mutually accessible research infrastructure, facilitating community-based, field-initiated research, data collection and sharing with adherence to commonly acceptable research regulatory policies and procedures in Saudi Arabia. So it will be a national hub for supporting a dynamic, impactful research alliance between and University for Research Excellence. It will explore the wellness maintenance, disease reversal and prevention, treatment effectiveness, chronic disease mapping, policy impact, life impact on wellness and illness, and clinical quality improvements. So research and studies are done across community settings, congruent with the work done in academic medical centers. So most of healthcare happens in tertiary and I mean, most of healthcare is happen in primary healthcare, but most of research happens at the tertiary and specialty hospitals. So there is different population. So clinical trials done in hospitals in tertiary hospital might not be applicable to primary healthcare settings. So the network is to answer community-based healthcare questions and translate research findings into meaningful everyday practice. So the network will enable and empower successful implementation of various nationwide studies, policy recommendations, disease mapping and translation research. Also to assist in realizing overall strategies for achieving improved healthcare for the nation. This includes asking important questions and advancing evidence-based practice related to primary care and healthcare transformation at all levels of care provision, and population health management, cost effectiveness, and team-based care. So we aim at initiating multiple studies each year. Studies will range from simple surveys to more complex designs. Our vision is to have a network organized and focused on the national research alliances between academic institutions, health clusters, health authorities, private health sector, and community practitioners conducting continuous impactful research. Mission is a quality impactful focused research that transfer healthcare practice from disease-centered care to a wellness-empowered practice. So our objective is to develop a network of academic and community-based research sites to facilitate the conduct of clinical research, public health, population management, lifestyle, and complementary and alternative medicine, and creating health care excellence through impactful research, policy recommendations, service line specific translation and research and education. And this is important, is to reduce funding and manpower stress on a single institution and spread the cost of doing research across all participating organizations and individuals. The objectives of the network is to have also a collaborative data analysis, scientific writing, and publication. Usually collaborative papers get more citations, multi-center studies and larger samples, and improve access to data to a larger number of researchers, increase the number of impactful translation research studies. So the leadership structure of the network will include key representation from all partners, the established C2-led scientific council with members from each partner institution that will oversee the network and set the research priorities. All research are subject to both IRB approvals, administrative approvals, and policy and procedure for the network scientific council. So there will be an electronic platform for the network, and will be accessible and secure. Will be flexible, that can adopt and managed by all centers and sites. Data registry and data bank will be user-friendly, and data entry to enhance data entry and retrieval. So it will be only for members and readable for non-members. Data elements will include site and provider information. So there will be a unique ID for each site and each provider, and there will be a de-identified patient information. Subject recruitment and retention, it's challenging in most of clinical research projects and networks. It's an important factor impacting the subject recruitment, include the study scope, disease epidemiology, complexity of intervention, and method of data collection. So community providers inclusion in early stages of the all study design is particularly important in subject recruitment and retention. Okay. One of the activities for the network education training. So education training will be available for all members of the research network, as well as newest medical education. Best practice network will deploy standards and develop a learning community through sharing of education resources. So the benefits of joining the practice-based national research network, it's to generate and grow research ideas and to develop projects, access to ideas and facilities, learn more about research, translate research results into practices to improve patient outcomes, large-scale studies and clinical trials, rapid distribution and use of research findings, and to facilitate collaborations that are sustained beyond any one project. So activities, there will be national webinars like on different issues, and also there will be an annual meeting and conference. There will be a registry for interested researchers and their interests, as well as disease registry and environmental and behavioral determinants. And there will be like a weekly newsletter. So currently there is more than 17 institutes from different administrative regions in the kingdom that will join the network from different regions, like from Tabuk to Job, Hail, Qasim, Riyadh, and Jazan. We will be initiating 5 studies this year on disease mapping. So we will include hypertension, hyperlipidemia, diabetes, pre-diabetes, and obesity, as well as have 5 intensive lifestyle intervention for those diseases. Yeah, so this is my last slide. This is a real quick review about complementary integrative medicine in Saudi Arabia, as it's included in the network. So it was estimated that the out-of-pocket expenditure in 2011 on complementary and alternative medicine practitioner visit and products was approximately around $8.2 billion. So this is around 33 billion riyals, while the governmental health sector budget allocation was 18 billion. So it's almost 40% they spend in CAM expenditures. And the CAM prevalence is common in the population, so it's ranges from 35% to 90%, and there is some population like pediatric oncology, 100% they have used the CAM. Thank you. Any questions? It will be very quick.
Thank you, Dr. Ayman, for this presentation. Any questions or anybody, if you are interested in any of this is actually is being done as we speak. I'm a team member with Dr. Ayman. I'm a team member. And we're working on this. We have some difficulties and issues, but inshallah ta'ala, we expect to launch all the studies. Actually, there is more than 10 studies, and on May 15th, inshallah ta'ala. So if you're from a different institution, we did not talk to you yet, so you could talk to us. And if you have a specialized center, like diabetes center here in Hail, you could also get involved, so you could study all of Hail. And Dr. Talal Al-Zabni here with us, he's the head of the IRB committee here and with the Hail cluster. I know there is benefits from this, is that you could compare your data to all the data across the country. Either could be provincial data, could be cluster data, but we try to stay away from biased data, like just tertiary care or secondary care data. So you would have also primary care data. The next phases will be going into the community, and at that level, I think the university would help with the manpower to conduct, surveys on a regular basis. We have one challenge I just want to mention, is that there are some people who think that doing multiple studies at different levels and even repeating the study is not necessary. And these people are in leadership positions, and that's sad, because there is no way for you to know unless you repeat it again and again, and you compare to somebody else's study. do research on the available services and other stuff, and also research on the outcome of either even the MOH translational or transformation efforts. Are they effective? Are we doing research to see if they're effective or not? So if there is any questions, please go ahead.
Thanks a lot, Dr. Ayman. Excellent. And I'm really very happy and we are trying to see what is happening inside the real community. We are just saying jargon inside our clinic, but people do what they believe they do since very long time. So this is very good that you are studying this now, trying to govern as much as you can. I hope if you do as much as you can qualitative studies. Qualitative studies, so you approach people, sit with people, give them time, take from their words, and then make thematic analysis for this qualitative multiple views with multiple people who are using this. This will be excellent. And the hope, if you can do a randomized control series of randomized control trial for whatever the approach of complementary and alternative medicine, this will be excellent actually. So we will be like an evidence provider, not like we did always evidence user and evidence look for what Western give to us.
Totally agree with you, Dr. Ayman. Yeah, sure. So, inshallah, we will have 5 randomized clinical trials like lifestyle, and in the future, yeah. So we will like be hearing from people what's going on, and so from the community, from the provider themselves, and yeah.
Question, comment? Sura? Okay. Thank you very much. Thank you, دكتور. يعطيك العافية. شكرا لكم جميعا. I want just attention, please, about now we have a picnic or trip or we have trip marathon and also go for some museum, and also there is some nice trip for you, and but please wearing the jacket or farwa, and also the we need also the sport shoes. Will be inshallah move from here at 3 o'clock.
Jubba, don't miss this one. If you haven't been to Jubba and you're not from Hail, you never been there. It's really a nice place to see. There is old ruins. You will see old technology on the mountains, like carriages, which is, you don't ever think there is carriages in this area 2,000, 3,000 years ago. Very hospitable people there. Mountains, it's a rural area, and also sand dunes. But it's cold. Bring your jacket, put on your shoes, be ready. If you need a snack, grab a snack before you go. And we'll see you all there. They said be ready at the gate about 2:30, so it's easy for everybody to get on a bus and we go there. And we'll be back before it gets really cold at